We have discussed how this class 1 agents actually block the sodium, but along with the sodium, they also can block the potassium, and some of them can activate the potassium channels also. Okay, those who block the potassium, they can cause the QT prolongation and they can increase the action potential duration, as we have discussed. Okay, then we have also discussed the phenomena of this use dependence. Okay, because of these drugs who have the strongest binding or the slowest dissociation, they will start working at a very high heart rates, just like your drug, which is the flecainide and the propafenone. They have a very high use dependence. They have the cumulative effect at very high heart rates, so they can actually reduce the heart rates. Okay, and can prevent the arrhythmia. And one important thing that I told you is you have to make sure that your heart is structurally normal. Okay, it do not have any infarction or any other condition or any dilation before giving these drugs. Class 1B drugs you only use in those conditions whenever you have a myocardial infarction, and after the myocardial infarction you are having the arrhythmias. Then only you can use the class 1B agents. And one more important thing that we have discussed about the lidocaine, that it is also used for the digoxin toxicity. Okay, we have discussed the class second agents, which are the beta blockers. Okay, that causes a decrease in the slope of the phase 4, as you can see. And because the slope of phase 4 is decreased, now it would take time to reach the threshold potential so that a new impulse or a new action potential could be generated by the SA node, right? And along with this phase 4, they also have an effect on the phase 3, which are the potassium channels. Okay, we have discussed about the class 3 agents, how amiodarone is belong to class 1, class 2, class 3, as well as class 4. It has a property of sodium blockage, the potassium blockage, okay, the calcium blockage also. So it can cause an increase in the PR wave. Okay, it causes a QRS widening. It can also cause a QT prolongation, and just like beta blockers and a class 4 agent, they can also reduce the sinus rate. Sotalol, which belongs to class 2 as well as class 3 agent, we have discussed how it can lead to an increase in the PR wave. Okay, the PR prolongation because of a class 2 activity. Similarly, because of the class 2 activity, it can reduce the sinus rate. Because of the class 3 activity, by this potassium blocking, it can cause a QT prolongation. Okay, then the tofidilate, which is specifically the class 3 agent, it can only cause the QT prolongation. We have discussed how in the amiodarone you have to you have to check the PFT, LFT, and the TFT. Okay, in case of lungs, it can cause a pulmonary fibrosis, so it would be a restricted lung disease. Okay, in case of liver, it can cause a hepatotoxicity, abdominal pain you will see. Okay, so you have to check the LFT count. Okay, the ALT AST ratios. For the thyroid, it can cause the hypothyroidism, so you also have to check TFT regularly. And we have discussed this amiodarone can deposit in your cornea, so you will see the blue and the grayish deposits in the cornea. Okay, and just like the class 4 agent, it can cause a constipation. Okay, and bradycardia, heart block, and heart failure can also cause, right? And amiodarone is the drug which has the least QT prolongation as compared to ibutylate, dofetilate, or the sotalol. And we have discussed how at a high heart rate, it can cause this QT shortening, not the QT prolongation, while the other drugs like class 1A agents, which shows the use dependence, so at a high heart rate, they actually can cause the more QT prolongation, right? So that's about these agents. Then the class 4 agents, which are the calcium channel blockers, they inhibit the calcium channels, and as a result, they can cause the decrease in the heart rate, okay, or increase in the AV node refractory period. Okay, they can also cause a decrease in the inotropic property of the heart, which is a loss of contractility. Okay, and so they are useful for the nodal arrhythmias or the supraventricular tachycardias. Okay, they don't have much effect on the myocardium itself. They have a major effect on the SA node and the AV nodes, right? And they can cause the constipation. Flushing and edema is mostly for the dihydropyridine calcium channel blockers. It is not a major property or a side effect of these the cardioselective calcium channel blockers or the non-dihydropyridine calcium channel blockers. Okay, but they can cause the heart failure or the AV block. Then other antiarrhythmic agents we have discussed, the adenosine. Okay, it acts to the A1 receptors in case of heart. It causes the hyperpolarization, right? And as a result, this wave will go very down. So it will take time to again reach to the threshold potential to cause a new impulse generation, right? So that's how it can reduce the heart rate. In case of blood vessels, you have the receptors which can cause the vasodilation for that instance. In case of lungs, they have the receptor which can cause the bronchospasm instead of bronchodilation. Okay, theophylline and caffeine, they are actually antagonists to the adenosine. So that's why theophylline could be used for the treatment of asthma also. Okay, and the magnesium, very important thing because it could be useful for the digoxin toxicity. Can anyone tell me other uses of magnesium?
Torsades.
Okay, torsades.
It's
Okay, so
also
that
used in asthma.
it's also in
Also
asthma.
used in
Eclampsia.
Yeah.
Exactly.
eclampsia.
Yeah, eclamptic seizures. It is very useful for that, right? Please remember the function. Then evaporatin, we have discussed how it inhibits the funny sodium channels. You all know where the funny sodium channels are. Okay, they are in the SA node, AV node, and they are used in the phase 4 because they causes the entry of the sodium inside the cell, in the cells, right, in the SA node cells. And as a result, the spontaneous depolarization can happen, right? By inhibiting these channels, this spontaneous depolarization can be slowed down, right? And as a result, you will get a reduced in heart rate. Okay, and because the myocardial oxygen demand would be reduced by these drugs, so you can have a you can use them for the treatment of chronic stable angina, right? And now we have finished the cardiovascular system, and today we will start with the endocrine. Okay, so first is the thyroid development. Okay, where the thyroid actually forms, it is forms in your pharynx. It is formed in your primitive pharynx. Okay, it is formed by the floor of the primitive pharynx. Can anyone tell me, which layer will form the thyroid? Ectoderm, mesoderm, or endoderm?
Endoderm.
Endoderm.
Yeah, please remember it is formed by the endoderm. Very important. And what about the parafollicular C cells?
Neural crest cells.
Yeah, it was initially thought that they were derived by the neural cells, but now it has changed. Now both the thyroid cells as well as the parafollicular C cells, they all are derived by the endoderms. Okay, both of them are by the endoderm. Okay, please remember this. Okay, so it is arised by a thyroid diverticulum, which is formed in the primitive pharynx. Okay, and then it descends into the neck. And to descend into the neck, it needs a path, right? And this path is formed by the thyroglossal duct. Very important. It is formed by the thyroglossal duct. And, when the thyroid actually forms in your pharynx, it reaches to the throat. Okay, then this thyroid duct, the thyroglossal duct must be disappear. Okay, very important. But sometimes it will be persisted as a cyst. Okay, very important. Sometimes it will be persisted as a cyst, and we will discuss that later, what will happen then. Okay, the foramen cecum, which is found in the tongue, if you guys remember, this is the tongue, let's say. This is the anterior two-third, and this is the posterior two-third. You have a cecum terminale, and here you have the foramen cecum, right? So this foramen cecum is actually a derivative or the remnant of the thyroglossal duct. Very important. Okay, and this duct is very important for the migration of the thyroid from pharynx to the throat. Okay, also trachea at its original location. So this thyroglossal duct is important, and the remnant is the foramen cecum. Very important. Okay. So as you can see, because thyroid has to travel all the way down to the throat, it can lodge anywhere in this pathway. Okay, and whenever it lodges anywhere in the pathway, it can lead to the formation of ectopic thyroid tissue. Okay, and the most common location is the tongue. Now it is known as the lingual thyroid. It is just posterior to the lung, to the tongue, and as a result, it can block your respiratory pathway, and it can block your GI pathway. Right. So what you can have is a dysphagia as well as a respiratory distress. Okay, because thyroid is kind of very posterior to that, right? And because of being the posterior, it can block the airway, right? So patient can have a difficulty in breathing, shortness of breath. Okay, and it can also block the esophagus. If it being posterior, then it can cause the dysphagia also. Okay, very important. And if you remove this gland, if it is the only gland in your body, the lingual thyroid, and you remove it, then it can lead to the hypothyroidism. Okay, very important. Now, not only this lingual thyroid, it can lodge anywhere. Okay, sublingual location also. Okay, supratracheal location also, anywhere in the pathway it can lodge, but most commonly it is in the tongue part. Okay, very important. So now comes the thyroglossal duct cyst. Like we have discussed, this thyroglossal duct must be disappear. Okay, by the birth. If it doesn't disappear, it can lead to the formation of thyroglossal duct cyst. So it is a midline mass. As you can see, the duct is almost midline, right? So it is a midline mass. Okay, and generally it moves whenever you move your mouth. Okay, whenever you try to chew something. Okay, whenever you try to speak, this thing, this duct, this cyst will also move along with the movement of the jaw. Okay, so it is present as the anterior midline swelling. Okay, very important, and that moves with the swallowing movements or the protrusion of the tongue. Okay, you also have something known as the uh, you also have the dermoid cyst. Okay, which is happened by the trapping of the skin structures. Okay, and it does not moves with the movement of the jaw, like swelling or or any speaking type movements. Okay, very important. So you have two midline masses. One is the thyroglossal duct cyst and second is the dermoid cyst. Dermoid cyst, it doesn't move with the movement of the jaw. Okay, but this thyroglossal duct cyst, it moves with the movement of the jaw. Okay, so please remember this, it is very important. Okay, it can be happen at any time in the lifetime of the individual, but it generally happen at a very initial stages. So the age of the patient is also very important. If it is a child, that means most probably chances that the patient is having a thyroglossal duct cyst. If it is an adult, that means a very high chances for the dermoid cyst. Okay, very important. And of course, the ectopic thyroid tissue can also be present in this thyroglossal duct cyst. Okay, very important. So yeah, that would be all. And thyroglossal duct cyst, they originate from the tongue, from the foramen cecum. It forms a foramen cecum ultimately, right? So remember these things. And you have also one test, which is a 99 ampere technique test. Okay, this test is also used for the Meckel's diverticulum. Okay, and it is used to detect the gastric mucosa mainly. Okay, but it can also be used in other conditions. One of them is a detection of the thyroid tissue. Okay, you will inject the dye in the body, and wherever the dye go, you can easily would do the imaging thing, and from the imaging you can see where the thyroid is located, right? So this 99 ampere technique test is also used for the thyroid tissue. Very important, remember this also. And the same test is also used for the Meckel's diverticulum. You will study that later in the GI section again. Okay, so just dismiss the development of thyroid. It is formed by the thyroid diverticulum from the primitive pharynx derived from the endoderm. Okay, and it uses the this thyroglossal duct to move from the pharynx to the throat part, right? And it can lodge anywhere along this pathway. Most commonly on the tongue, known as the lingual thyroid. It can block the respiratory passage. It can cause the respiratory distress. Okay, and it can also sometimes cause as a mass. If it is sublingual, it can also present as a mass, right? And yeah, it can cause hypothyroidism if you remove that 99 m. This polytechnic test must be remembered thing. Okay, the thyroglossal duct cyst is a remembering thing, must remember thing, right? It will move along with the movement of the jaw, but a dermoid cyst, it doesn't move with the movement of jaw. That is a main difference. The parafollicular C cells, they are derived from the endodermal cells. Can anyone tell me uh, what structures from the parafollicular C cells?
Ultimobronchial body.
Yes. And is it the arch or the pouch or the cleft that forms them?
Pouch.
Pouch. Which pouches?
Third and fourth.
Third and fourth pouch. Very important. You have two sets, the upper part and the upper C cells and the lower part. Okay. So very important to note that. Sorry, that was a different thing. Okay. Then comes the anatomy. Okay, for the pituitary gland, you have two parts of the pituitary. Okay, one is the anterior pituitary and second is the posterior pituitary. The anterior pituitary is known as the adenohypophysis. Okay, and the posterior pituitary is known as the neurohypophysis. The adenohypophysis is derived from the oral ectoderm. Very important. It is derived from the roof of your oral cavity. Okay, okay, which is known as the Rathke's pouch. Okay, it is the ectoderm. Okay, after the oral cavity, the whole part of your GI system is the endoderm. Okay, the pharynx part, the esophagus, the stomach, and every other organ. Okay, in the GI tract, it is the endodermal part, right? But the oral cavity is derived from the ectoderm. Okay, and this adenohypophysis is derived from the roof of the oral cavity, known as the Rathke's pouch. Okay, which forms it. So it is a part of your ectoderm. Okay, the neurohypophysis, it is made by the neuroectoderm. Very important. So do not confuse between them. The neurohypophysis is formed by the neuroectoderm, and the adenohypophysis is formed by the oral ectoderm. Okay, most of the most of the hormones are secreted by the adenohypophysis, like the FSH, LH, ACTH, TSH, prolactin, and many others. Okay, we have the alpha and the beta subunits. Okay, alpha subunit, and most commonly, okay, they are from the TSH, LH, FSH, and beta HCG. Okay, and beta subunit is very specific for a hormone. Okay, if you guys remember about the beta HCG, right, it is very specific for the HCG only. But the alpha part of the HCG, okay, they have a common, things in the like FSH, LH, and the TSH. They all have a same unit, alpha subunit. Okay, so if you measure the alpha HCG levels, then you can check, this alpha HCG can mimic the LH, FSH, and TSH also, right? But beta HCG is very specific thing. Okay, it has a hormone specificity, but alpha subunit is very common to all of them, right? So that's why in the scenarios where you have a high beta HCG count, can anyone tell me what scenarios? In what condition you can have a very high HCG count?
Gestational
Pregnancy.
trophoblastic disease.
Yeah, exactly. So in all these conditions, you also have the hyperthyroidism. Why? Because the alpha subunit of this HCG, it also mimics the TSH functions. Okay, so in these scenarios, you can also have a hyperthyroidism. That's why, because alpha subunits is kind of common, but beta one is mostly used for the exact for measuring the exact levels of the HCG. That's why you always measure the beta HCG, not the alpha HCG. Okay, very important. Then comes
Can
the
you repeat the
postpituitary.
condition again?
Yeah,
Can you
ask it
repeat
again,
the
please.
condition? What was the condition for beta?
The gestational
For beta
trophoblastic
HCG,
diseases.
which was the condition?
Gestational trophoblastic diseases in which you
Okay.
have a very high beta HCG count. Okay, so you measure the beta HCG, not the alpha part, because beta, is very specific. Alpha is common to all of those hormones that you can see, the TSH, the FSH, the LH, and the beta, and this HCG also. Okay, but beta one is very specific. So in all these conditions where you have a high beta HCG count, like the gestational trophoblastic diseases, okay, or the cancer like choriocarcinoma, okay, in all these conditions you can also have a hyperthyroidism. Okay, because this beta HCG is because this HCG also have an alpha subunit which can mimic the TSH also, right? So they can cause the hyperthyroidism in these scenarios. Okay.
I have one question.
Yeah, do ask.
You were talking about those third and fourth brachial pouches.
Yes.
Over there, do the parafollicular C cells derive
Yeah,
from V and third and fourth pouch, or the parathyroid glands?
both actually.
Okay, okay. Got it.
Both of them are derived from them. Okay, both
Okay.
things.
Thank you.
Okay, now comes the neurohypophysis. Okay, it releases the vasopressin and the oxytocin. Very important. It releases the vasopressin and the oxytocin. Does anyone remember the receptors for the vasopressin?
V1 and V2.
And what kind of V1 receptors are? G protein coupled. What kind of G protein coupled?
GQ.
GQ. And what are V2? They are GS type. Okay, very important. So GS type, which are the V2, they are actually found in the collecting duct. Okay, but the V1 type receptors, which are GQ type, which causes the vasoconstrictions, and that's why the name vasopressin, they are found in the blood vessels. So V1 receptors in the blood vessels and V2 receptors in the collecting duct. In the collecting duct, they causes the reabsorption of the water only, not the sodium, but only the water because of the aquaporins. You will study that later in the renal section. Okay, So please remember that. Oxytocin, they have their own receptors which can cause a contraction. Okay. And both are made by the hypothalamus. Okay. Both are made by the hypothalamus, the supraoptic and the paraventricular nuclei. Why I'm saying nuclei?
Please repeat once.
I'm saying supraoptic and paraventricular nuclei. What does this nuclei is?
So
These
they're
are the
basic
collection
collection
of
of
cell in the CNS.
Exactly. So these are collection of cell bodies in the CNS. Actually, hypothalamus is nothing but but made up of only the neurons, right? So these are the neurons which are modified to secrete these these hormones instead of the neurotransmitters. Okay, cell body of the neurons, they made all the neurotransmitters and all the hormones. Okay, and if I annotate it, then you have the cell body in the hypothalamus. Okay, and the axon part is in the pituitary gland. Okay, so this is the hypothalamus. This is the neurohypophysis. Okay, and this is the tract for the transfer of these substances, these hormones. Okay, so in the in these axon terminals, it is where they have stored in the pituitary, right? So they are synthesized in the cell body or the nuclei, the collection of cell bodies, and then they're stored in the axonal part, the end of the axons, in the vesicles. Okay, that's why. Okay, so whenever in the use, they will be always secreted from the the neurohypophysis, and because the neurohypophysis are secreting these hormones directly into the blood, that means I can say that at the pituitary there is no blood-brain barrier present. Is that okay?
yes.
Okay, please remember, no blood-brain barrier in the neurohypophysis because they are directly secreting the hormones in the blood. Okay, it is very important to note. And the carrier proteins through which all these neurotransmitters or the hormones they actually reach in the neurohypophysis are the neurophycins. So whenever you have an increased release of these hormones, you always have an increase in concentration of the neurophycins. Very important also. Okay. Then comes the adrenal cortex and the adrenal medulla. Okay. For the adrenal glands, you have two parts. Outer one is known as the cortex, and the inner one is known as the medulla. Okay. The cortex part, it is derived from the mesoderm, very important. And the medulla part, it is derived from the neural growth cells. Because you guys know that they are involved in the synthesis of neurotransmitter, that means they are the neuronal structures. They are formed by the neural growth cells. The adrenal cortex, they synthesize these hormones. So they are from the mesoderm. Okay, very important. All these steroid hormones, right? So for the cortex part, it is divided into the three zones: the zona glomerulosa, fasciculata, and the reticularis. Glomerulosa, fasciculata, and the reticularis. For the glomerulosa, they synthesize the this aldosterone. Okay, they synthesize this aldosterone. Okay, and it is regulated by the angiotensin 2. Okay, whenever the RAS system get activated, it will release the angiotensinogen. Angiotensinogen will be converted into the activated form, which is angiotensin 1. Angiotensin 1 will be converted into the angiotensin 2. Angiotensin 2 will come, will be secreted in the blood. From the blood, it will reach to the adrenal glands. Okay, and the adrenal glands, they will secrete the aldosterone by the mineralocorticoid cells or the zonal glomerular cells. Okay, and not just the angiotensin. If the potassium levels get too much, in case of hyperkalemia also, this aldosterone can be directly secreted from the adrenal glands. Very important. Angiotensin 2, as well as the potassium levels, hyperkalemia is also a factor for the synthesis of this aldosterone. Then comes the zona fasciculata, which secretes the ACTH, okay, and the CRH also. Sorry, it is regulated by the ACTH and CRH and secretes the cortisol. Very important, it secretes the cortisol in response to ACTH and the CRH. Okay. Similarly, this ACTH also regulates the reticularis, the zona reticularis, which secretes the DHEA, okay, or your endostern dienediones. Okay, they also be secreted by the zona reticularis. Okay. Then comes the medulla, which has the chromaffin cells. Okay, and these chromaffin cells are the paraganglionic sympathetic fibers. Very important. They are they're regulated by the preganglionic sympathetic fibers. And can anyone remember what the sympathetic fibers actually releases?
Acetylcholine.
Acetylcholine.
Yeah, very important. They releases the acetylcholine, and in response to the acetylcholine, the chromaffin cells secretes the epinephrine and the non-epinephrine. And you guys must remember the fact that every nerve ending, okay, as a neurotransmitter, in case of a post-ganglionic neurotransmitters, they always releases the this non-epinephrine, right? And only in the chromaffin cells, the epinephrine can be formed. Okay, so epinephrine can only be formed in the chromaffin cells, and it is directly released into the blood vessels, right? But the non-epinephrine, it is formed by the nerve endings, okay, in the neurons itself. So whenever we talk about this the neuronal cells, the cleft of the neurons, okay, the synapse part, it is always with the non-epinephrine, not the epinephrine. Okay, must remember thing. And yeah, that's all. And this cortisol is also responsible for the synthesis of epinephrine and non-epinephrine. As you can see, the veins, the outermost structures are AC zona glomerulosa, then fasciculata and the reticularis. And the venous drainage pathway is in the same way. Okay, the veins first drain the blood from the glomerulosa, then the fasciculata, then the reticularis, and then the chromaffin cells. Okay, so cortisol, which is formed by the fasciculata, it reaches to the chromaffin cells. Okay, and when it reaches the chromaffin cells, it can synthesize the epinephrine and the non-epinephrine. Okay, so if you inhibit the cortisol somehow, okay, then you can also treat a condition known as the pheochromocytome. Very important. And the enzyme name is the PNMT, which forms the epinephrine in these chromaffin cells. Okay, and cortisol is a positive regulator of this PNMT enzyme. So if you inhibit the cortisol, then you can also treat the pheochromocytoma. Very important. And yeah, you must know the histology of this adrenal cortex and the medulla part. You will get a very sharp demarcation, okay, between the cortex and the medulla. Yeah. Then a brown fat, okay, or the brown adipose tissue, which is found, found near to the adrenal glands also, and it is only present in the babies, okay, or the neonates, I must say, okay, because they have a kind of very immature type of sympathetic and the parasympathetic nervous system. Okay, so in order to maintain the heat, okay, they're dependent on these brown fat. Okay, they cannot cause more shivering just like the adults. Okay, so the only way to maintain the heat in the body is by these brown fats. Okay, and these brown fats, they have more mitochondria than the white fat. Okay, and they also have a very high permeability of the mitochondria. And if you guys remember from the biochemistry lectures, if you have a very high permeability in the mitochondria, then the H plus ions will be leaked out of the mitochondria inside the matrix of the mitochondria, right? And because of this leakage of the H plus ions, the heat will be lost. Okay, then the energy will be lost in the form of heat. Okay, so that is a way to generate the heat in the babies. Very important. Remember this thing also. And yeah, that would be all about anatomy. Any doubt? Please ask.
No, thank you.
Just remember the location. Okay, these are suprarenal glands. Okay, two parts, the cortex and the medulla. Please remember the cortex, glomerulosa, fasciculata, reticularis, which hormone they synthesized. Okay, and in response to which hormones they're synthesizing them. Okay, for the pituitary, two parts, adenohypophysis, neurohypophysis. Adenohypophysis for the ectoderm, oral ectoderm, and the neurohypophysis for the neuroectoderm. Okay, Rakesh spouse, please remember these. Hormones are very important. Only two hormones from the neurohypophysis, which are stored in them, not synthesized by them. Okay, these are the oxytocin and the vasopressin. Okay, and remember this part of the cortisol, which is responsible for the synthesis of epinephrine. Without cortisol, you cannot synthesize epinephrine. Okay, remember the function of this brown fat for the heat generation. They have a very high permeability of the mitochondria, so that the H plus ions can be leaked and the energy will be lost in the form of heat. Remember the cells which form this cortex part and the medulla part. These are the mesoderm cells. And because they are derived from the neuronal cells, so whenever the patient get a pheochromocytoma, they will always have a high markers of the neuronal markers. If you guys remember, okay, then the synaptophysin, the neurogranin, okay, they all will be raised in the pheochromocytoma also. Okay, then the hypothalamic pituitary hormones. Okay, first one is the ADH. Okay, it is also known as the vasopressin. Okay, it increases, like I said, they have two receptors, the V1 receptor and the V2 receptors. V1 receptors, they are found in the blood vessels, and the V2 receptors, they are found in the collecting duct. In the collecting duct, whenever the V2 receptors become activated, they will activate the aquaporins. Okay, so that the permeability for the water, you know, by this by this, the DCT and the collecting duct would be increased, so that the reabsorption of the water will be increased. Please remember, not the sodium reabsorption, but the water reabsorption only. Okay, it is by the aquaporins, by the activation of this ADH. Okay, so what are the stimulus for the secretion of the ADH? First is of course a RAS activation. Whenever you have a RAS activation, they can activate the ADH also at the same time. Okay, second thing is the plasma osmolality. Very important thing is the plasma osmolality. Okay, whenever the plasma osmolality is increased, then the free water must be absorbed by the kidney to maintain the plasma osmolality to normal, right? So increased plasma osmolality is a factor for that. Whenever you get the dehydration, doesn't matter if you have a high osmolality or not. If you get the dehydration, okay, then also this ADH will be secreted to maintain the water in your body. Okay, very important. Then comes the CRH. Okay, and it is basically it is released by the hypothalamus. Okay, from the hypothalamus it goes to the pituitary. In the pituitary, it causes the increased release of ACTH. Okay, then it can also release the MSH and the beta endorphin. It is a very important thing. The CRH can cause the release of ACTH, MSH, and the beta endorphin. So they all are secreted by the same thing. Okay, very important. Just give me a second, guys. Yeah, sorry about that. So this ACTH, MSH, and the beta endorphins, they have a same hormones which causes the secretion of them. Okay, same origination. Okay, you will study that later how this how the release of ACTH can also cause the hyperpigmentation, which is because of this release of MSH. Okay, so just wait for the moment. Okay, then comes the dopamine. Dopamine actually causes the decreased release of this prolactin. Very important. One important function of the dopamine is the decreased release of prolactin, and second is the TSH decrease. Okay, so it can decrease the TSH also as well as the prolactin. Very important. So whenever you have a low dopamine levels, okay, in that case you can have a high prolactin level that can cause the galactorrhea or the gynecomastia, right? And if you remember from the biochemistry, we have discussed how in case of this disease,
Phenylketonuria.
phenylketonuria, okay, you have two ways to get the phenylketonuria. One is a deficiency of BH4 or the tetrahydrobiopterin, and second is a deficiency of tyrosine hydroxylase. Sorry, not tyrosine hydroxylase. What is that?
Phenylalanine
Yeah, phenylalanine hydroxylase. Okay, so in case of phenylalanine hydroxylase, if you take the tyrosine, then you can convert the tyrosine into the dopamine somehow, right? But in case of a tetrahydrobiopterin deficiency, okay, you cannot convert a tyrosine into the dopamine. So as a result, in case of a tetrahydrobiopterin deficiency, you will get the high prolactin levels, okay, but not in the normal phenylketonuria, right? So a most important point, dopamine actually decreases the release of prolactin. Okay, and it also decreases the release of TSH to cause the hypothyroidism, right? Then comes the growth hormone, regulatory hormone. It is released by the hypothalamus. Okay, from hypothalamus it reaches to the pituitary, the adenohypophysis. From there it can release the growth hormone. Okay, very important. And also very important thing, The analog of the of this growth hormone, it is used for the HIV associated lipodystrophy. Can anyone tell me which drug can cause a lipodystrophy in the HIV? Which drug class can cause them?
Protease inhibitors.
Yeah,
Protease inhibitors.
exactly. Protease inhibitors can cause a lipodystrophy, and for the treatment of this condition, you use the growth hormone analogs. Then comes the GnRH, again released by the hypothalamus. They will reach the pituitary to release the FSH and LH. Okay, and please remember, whenever you have a prolactin in your body, okay, they will suppress the release of FSH and LH. So prolactin is a negative regulator of the FSH and LH. Very important. Okay, and you have a this GnRH must be secreted in a pulsatile manner. Okay, this GnRH must be secreted in the pulsatile manner to increase the release of FSH and LH. Whenever you have a GnRH release in a continuous manner, okay, no pulsatile, but in the continuous manner, then in that case, they will decrease the release of FSH and LH, and that is the function of the leuprolide. Leuprolide is a long-acting agent. Okay, you give one dose to the patient. Okay, and it will cause the continuous release of the GnRH. And because of the continuous release of the GnRH, it can actually decreases the release of FSH and LH. Okay, so if the pulsatile GnRH secretion occur, that can lead to the high FSH and LH. If the continuous release occur, that can lead to the inhibition of the FSH and LH release. Very important. Then comes the melanocyte stimulating hormone, okay, released by the hypothalamus. It reaches to the melanocytes, and by the melanocytes, they increase the release of melanin. Okay, and if you guys remember, the CRH actually causes the increased release of ACTH as well as the MSH, right? Very important. So this MSH, and that's why whenever you have a high ACTH level, like in case of a hypoaldosteronism or the Addison's disease, you will have a high ACTH count, right? And that's why the patient is also having the hyperpigmentation, right? Because the CRH, which released from the hypothalamus, they will go to the pituitary. From the pituitary, it causes the increased release of ACTH, MSH, as well as the beta endorphins. That's why you always get the hyperpigmentation in case of hypoaldosteronism, right? So MSH released from the pituitary, not the hypothalamus, but the pituitary. It causes the release of melanin by the melanocytes. Very important. And the same reason, if you get the Cushing's disease with high ACTH, you can also get the hyperpigmentation, right? Very important. Then comes the oxytocin, which is released by the neurohypophysin, secreted by the hypothalamus. Okay, it causes a uterine contractions during the labor. Very important. And can anyone tell me why these coordinated contractions occur in the uterus in response to oxytocin? What kind of channels are responsible for that? Or a connection between the cells which are responsible for that? We have discussed that in the biochemistry, if anyone remember. The gap junctions or the connexons, if anyone remember, right?
Yeah.
Please remember the gap junctions or the connexons, they are always responsible for any coordinated movement or a coordinated contraction. Like in case of heart, okay, you get the coordinated contraction of the ventricles, and it is because of these gap junctions only, right? In case of oxytocin, when it stimulates the when it stimulates the labor, then in that case also you have a coordinated contraction of the uterus, and that is because of the gap junctions, so that the cells can connect to each other, right? And it is also responsible for the milk letdown response. Okay, so milk formation is by the prolactin, and the release of the milk is because of the oxytocin. Okay, very important. It also modulates the fear, anxiety, love, social bonding, mood, depression, and other things. Okay, they are the higher functions of the oxytocin. Then comes the prolactin. Okay, prolactin actually suppresses the GnRH release, and that's why it can cause the negative feedback to the FSH and LH release. Okay, it also stimulates the lactogenesis. Okay, dopamine can inhibit the prolactin, right? Very important. And one most important thing, whenever you have a high estrogen level in the body, the estrogen actually a positive regulator of the prolactin. So estrogen causes the release of prolactin, and in response, the prolactin causes the inhibition of the estrogen release. Okay, by inhibiting the FSH and LH. Very important. Estrogen can cause the increased release of prolactin. Okay, but in response, the prolactin causes the decreased release of FSH and LH, so decreased release of estrogen. Okay, another important thing, the TRH. Okay, it causes which is released from the hypothalamus. It causes the increased release of prolactin. Okay, so whenever you have a hypothyroidism, okay, in case of hypothyroidism, you're going to have a high level of TSH as well as high level of TRH. Okay, and this TRH actually causes the increased release of prolactin. Very important. And that's why in case of hypothyroidism, you can have a high prolactin levels. Very important. So whenever you have a pituitary prolactinoma, that can cause the amenorrhea by inhibiting the FSH and LH. Okay, you can have a osteoporosis because the estrogen won't be available, and you know that estrogen actually causes the bone growth. Okay, hypogonadism, it can happen because of loss of LSH and FH. It can cause a galactorrhea by increasing the milk secretion. It can cause the gynecomastia also, right? Very important. Then comes the somatostatins, okay, which actually decreases GH, TSH, insulin, okay, the glucagon and everything you can think about. Okay, it is always a negative type hormone. Okay, so it is also known as a growth hormone, inhibiting hormone used in the treatment of acromegaly. Can anyone remember the name of the analog for the somatostatin?
Octreotide.
Octreotide. Yeah, octreotide is an analog for a somatostatin, which is a drug used for the treatment of acromegaly. Okay, very important. Then the TRH released from the hypothalamus, it will reach the pituitary. From the pituitary, it can increase the release of TSH and increase the release of prolactin. Very important. So whenever you have a hypothyroidism, primary or a secondary type, not a tertiary one, but the primary or the secondary type, they can all increase the release of TRH. Okay, and in that case, you can also have the galactorrhea. Other very important. Okay, so in order to summarize, if you think about all the hormones, the somatostatins can inhibit the TSH. Somatostatins can inhibit the growth hormone. Growth hormone, regulatory hormone, is responsible for the release of growth hormone. TRH increases the release of TSH. Okay, and TRH also increases the release of prolactin. Dopamine can inhibit the prolactin release. Okay, and this prolactin in response will inhibit the release of GnRH, so that the LH and FSH could not be released. Okay, and yeah, and this dopamine can also inhibit the release of TSH. Okay, that's the summary of all these things. Okay, any doubt on this page?
I have a question from the previous page. Like, hello.
Yes, please ask.
You were saying that the blood-brain barrier is absent in the hypothalamus.
No, not in the hypothalamus, in the pituitary.
Okay, so it's the complete pituitary.
Not only the neurohypophysis part. I think. No, it could be a complete pituitary because adenohypophysis should also release a hormone in the blood, right?
Yeah.
So complete pituitary.
And also the hypothalamus is releasing the hormones in the blood. So does it mean that even the hypothalamus is not having the blood-brain barrier?
Well, mostly it releases only in case whenever the pituitary get damaged, right? Is one way. It will take over the functions. They will take hypothalamus should have to take over the functions only in case when the pituitary get damaged. If you guys remember, okay.
Yeah.
Then the hypothalamus will directly releases the oxytocin and the vasopressin in the blood, and in that case, yes, the blood-brain barrier will be lost from there. And there are certain locations in the hypothalamus where the blood-brain barrier is not present, and you will see that in the neurology section about that. Okay, there are many locations in the hypothalamus which are devoid of the blood-brain barrier. So yeah, and from there it can release the hormones for the adenohypophysis. Okay.
Okay. Got it. Thank you.
I have a question.
Yeah, do
You
ask.
were discussing something about phenylketonuria. Can you repeat it?
Yes. See, in case of a phenylketonuria, what's gonna happen? You have this, you have the formations, increased formation of the phenylketones. Okay. So first of all, you have the phenylalanine in the body. This phenylalanine, which is here, it is converted into the tyrosine. Okay, and it is by the two enzymes. Okay, one is the phenylalanine hydroxylase, and second is the tetrahydrobiopterin. Okay, both of these enzymes, okay, they will convert the phenylalanine into the tyrosine, right? This tyrosine will be converted to the this dopa. Okay, or okay, and it is by two enzymes again, the tyrosine hydroxylase, okay, and the tetrahydrobiopterin. Now you can see that the tetrahydrobiopterin is required for the conversion of phenylalanine to the tyrosine and tyrosine to the dopa. And finally, this dopa will be forming the dopamine, right? So in case if you have a deficiency of the phenylalanine hydroxylase, then you cannot convert the phenylalanine into the tyrosine, right? And that's how you can get the phenylketonuria. But in case, and for the treatment of the phenylketonuria, you generally uses the tyrosine supplements. Okay, so that uh, this thing will be converted into the dopamine, right? And then to the norepinephrine and epinephrine, right? But in case if you have a deficiency of the tetrahydrobiopterin, then what's gonna happen? Even if you take the supplements of the tyrosine, okay, you still require the tetrahydrobiopterin to convert it into the dopa, right? So in case of the tetrahydrobiopterin deficiency, the tyrosine cannot be converted into the dopamine. And as a result, you will get the low dopamine level, right? And because of this low dopamine level, you can have the hyperprolactinemia, right?
Yeah. Yeah. Yeah.
Is that okay, or should I repeat it again?
No. I just got it. The point. Thank
Okay, so
you.
please remember two enzymes. Two enzymes. One is the phenylalanine hydroxylase, and second is the tetrahydrobiopterin or BH4. In case of a BH4 deficiency, even if you take the tyrosine, it cannot be converted into the dopamine, so you will get the hyperprolactinemia. But in case of a phenylalanine hydroxylase deficiency, if you take the tyrosine in the supplements, then it could be converted into the dopamine, so you won't get the hyperprolactinemia. Okay, but in both the conditions, you can get the phenylketonuria, of course.
I actually had one more question going off of the PKU.
Yes.
When a mother with PKU is pregnant, you have to
Yes.
give her supplements. Is the supplements, are they going to have an effect on her, or is it to prevent the toxin buildup in her baby? Because doesn't the mother like grow out of her PKU deficiency?
Sorry,
I had
I didn't understand your question.
Okay, so when a mother has a PKU deficiency,
Yes.
eventually like grows out of it, right? So it doesn't like
Yeah.
affect her as much anymore. But when she becomes pregnant, why does she have
Yeah.
to go back to taking the PKU supplements? Is it for her, or is it for like, is it because she's making toxins that are going to the baby, or is it because the baby might have
So you are
PKU?
asking a mother with PKU and why she is taking a supplement, you are asking.
Yes.
Of course, for her as well as the baby, of course.
Okay, because
You
I
need a
thought that
supplements.
she wouldn't have that
Yeah.
anymore.
Yeah.
I thought that after a point in, maybe I misunderstood I had a question a while back, but I think I might have misunderstood it.
Okay.
Thank you.
Thank you. Okay. Any more doubt on these two pages?
No, thank you.
Just remember what hormones synthesizing what kind of hormones, and these hormones giving negative feedback to what other hormones, right? This is the only thing that you must understand from this page. Okay, then
Dr.
comes
Chaudhary, could
the,
you
yeah.
could just repeat what you wrote here? Like in green, prolactin can be due to.
Oh, we have discussed that.
Uh,
See, the estrogen actually causes the increased release of prolactin, right? We have discussed that. And in response, the prolactin inhibit the FSH and LH, and so that it could decrease the estrogen, right?
yes.
So whenever you give the patient OCP or the estrogen therapy, that can also lead to an increased release in the prolactin, right? Very important. And in case of a hypothyroidism, you will have the increased release of TRH that can cause an increased release of prolactin, right?
Okay. And what about the thing you wrote, pituitary adenoma, something was there?
Yeah, that's the same thing. The pituitary this tumor, the prolactinoma. In case of this, you will have a high prolactin levels, right? And in response to a high prolactin level, you are suppressing the estrogen levels, right? So you can get the this osteoporosis, you will get the amenorrhea, and because of hypolectin level, you will get the galactorrhea. Okay, and you will also get the hypogonadism because of loss of estrogen and FSH and LH responses, right? That is it. And the most common pituitary adenoma is this tumor only. The most common one is this, the polyactinoma. Okay.
What did you write next to pituitary adenoma? Is it like a arrow up or down or something?
This is and.
And okay, it's just a third point. Okay, got it.
Yeah.
Thank you.
It's just the causes of the hypolectin, which is the OCP therapy, okay, the TRH or the insulin therapy or the pituitary adenoma. These three causes for the hyperprolactin levels. Okay, then comes the growth hormone, the function of the growth hormone. Like we have discussed, the growth hormone, regulatory hormone, it is synthesized in the hypothalamus. From the hypothalamus, it will be transferred to the this anterior pituitary or the adenohypophysis. Okay, in the adenohypophysis, in response to this growth hormone, regulatory hormone, the growth hormone is released. Okay, now this growth hormone must go to the liver first. Okay, and from the liver, it releases the insulin-like growth factor 1. Very important, insulin-like growth factor 1. It is also known as the somatomedin C. So step 1 can give you any name, either the IGF-1 or the somatomedin C. Okay, now major function is of this IGF-1 and the minor function is of the growth hormone. The growth hormone will go to the adipose tissue, and from the adipose tissue, it decreases the glucose uptake. Okay, it causes the insulin resistance. Very important. So it can cause the hyperglycemia, right? And it can also cause the lipolysis. So two things. One is the decrease in the glucose uptake, okay, or I can say the insulin resistance. Second thing is the increase in the lipolysis. So it will release the free fatty acids, and these free fatty acids will go to the liver and will be converted back into the glucose again, right? They will take part in the gluconeogenesis and the formation of ketone bodies, right? So lipolysis and the decrease in glucose uptake for the growth hormone. And second thing is the release of insulin-like growth factor 1. Now this insulin-like growth factor 1, it will go to the bone and it will cause the bone growth in any way, right? And for the growth of the bone, the amino acids must be there for the formation of proteins. So they will cause an increased amino acid uptake. After the increased amino acid uptake, it can cause the protein formation, the protein synthesis. For the protein synthesis, you require the DNA and RNA. So it will cause the DNA and RNA synthesis. Okay, it will cause a chondrin sulfate, which is a bone, a part of the bone. Okay, the chondrin sulfate. It will cause the increased release of collagen. Can anyone remember what is the collagen type in the bone?
1.
Type 1 collagen. Yeah, it will cause a type 1 collagen. It will also cause the increase in the cell size and the cell number. Okay, very important. So in any way, like it is doing everything inside the cell to causes the bone growth. Okay, for the muscles, similarly, it will go to the muscle, and in the muscle, it will cause the amino acid uptake, and it will cause the protein synthesis. Also, the DNA and RNA synthesis also, right? Very important. So for the muscle growth and the bone growth, IGF-1, which is released by the growth hormone. Okay, for the hyperglycemia or high glucose level, it is by the directly growth hormones, right? Like they will decrease the glucose uptake and they will cause the increased release of free fatty acids. Very important. Now, when the glucose is formed from the cells, okay, in case of hyperglycemia, the glucose is a negative, this glucose gives the negative feedback to the growth hormone regulatory hormone. Very important. Okay, plus the aging and the obesity also. Okay, they will cause some negative feedback to the growth hormone regulatory hormone, right? This IGF-1, it will also cause the negative feedback to the growth hormone as well as the growth hormone regulatory hormone. Okay, the growth hormone also gives negative feedback to itself as well as the negative feedback to the hypothalamus. Okay, so growth hormone, IGF-1, glucose, obesity, aging, they all will decrease the growth hormone regulatory hormone. Okay, and in case of sleep, in case of hypoglycemia, in case of stress, okay, you will have an increased release of growth hormone. Okay, so sleep causes the increased release of growth hormone, right? Hypoglycemia, just like that, because the function of growth hormone is to increase the glucose level. So in case of hypoglycemia, you will have a increased release of this GHRH. Stress can also cause the hyperglycemia. One of the ways the growth hormone. Okay, so that's everything which this it is written here. It is also a somatotropin secreted by the anterior pituitary. It stimulates the linear growth of the of the bone and the muscle mass through IGF-1, also known as a somatomedin C. Please remember the location. It is secreted by the liver. Okay, and directly this growth hormone can cause the insulin resistance. Okay, it is released in the pulses in response to the growth hormone regulatory hormone, and secretions will be increased in case of deep sleep, pituitary, and the puberty, and in case of hypoglycemia. Okay, chronic kidney disease can also cause the increased release, because in case of a chronic kidney disease, all the hormones which should be excreted by the kidney, they will remain in the blood, and when they remain in the blood, they can cause the increased release of these growth hormones, right? So in case of CKD, you will have a high level of these hormones. Okay, and the secretion will be decreased by the glucose itself, by the somatostatins. Somatostatins, remember, the octreotide and somatostatin, they will decrease the release of growth hormone. So the somatostatins analogs are used for the treatment of acromegaly. Okay, and somatomedins, they are secreted by the liver, and they will give the negative feedback also, right? Very important. So if you have a high level of IGF-1, then they will stimulate the growth plate in the bone, and they will cause the linear bone growth without causing the inhibition of the this growth plate. Okay. Similarly, you have the estrogen in the body. Okay. This estrogen also stimulates the bone growth by acting on this growth plate, right? But what is the difference between the IGF-1 and the estrogen? See, IGF-1 do not causes the closure of the growth plate or the metaphyseal plate, right? But in case of the estrogen, at the same time it is causing the bone growth. Okay, same time it is also closing the metaphyseal plate, right? So initially the patient will have a this growth spurt. Okay, they will have a very high height. Okay, but at the end of the puberty, okay, they will remain short stature. Very important. When the estrogen is acting on the bone, it will be causing the bone growth, but at the same time, it is also closing the metaphyseal plate. So initially, if the patient is having a very high estrogen level, okay, then at the very starting of the puberty, they will have a very, a very long height or a large height, okay, but at the end of the puberty, they will remain short stature, despite having an initial growth spurt. They will remain short stature. But in case of a gigantism, which is caused by the insulin-like growth factor 1, they only causes the epiphyseal or the metaphyseal growth plate stimulation without closing them. Okay, that's why you only get the gigantism. Very important point. Okay. Any doubt on the growth hormone?
No, no.
Okay. Then comes the antidiuretic hormone, or the ADH, also known as the vasopressin. Okay. So it is synthesized in the hypothalamus, if you guys remember, the supraoptic and the paraventricular nuclei. Okay, from the hypothalamus, it will be stored in the pituitary, the posterior pituitary. Okay, and neurophyzins are the transporter substances which are secreted along with the vasopressin and the oxytocin. Okay, they have the V1 receptors and the V2 receptors. V1 receptors are responsible for the vasopressin function. Okay, they causes the vasoconstriction to increase the blood pressure. Okay, V2 receptors, which are found in the DCT and the collecting duct of the kidney. From there, it will increase the permeability of the water so that more water could be reabsorbed, and it is done by the aquaporins. Aquaporine channels are there in the collecting duct. Whenever they get activated, they will causes the increased reabsorption of the water. Okay, very important. Regulation is the hypovolemia, like we have discussed. If you it doesn't matter if you have a high osmolarity or the low osmolarity. If the patient got a dehydration or the hypovolemia, this ADS will be secreted. Okay, and even if you have a high volume, okay, but if you have a high osmolality, so two things: one is the osmolality, and second is the volume. If you have the high osmolality, the ADS will be secreted, more water will be reabsorbed, free water, to maintain the osmolality, this osmolality level. If you have the hypovolemia, then again more water will be reabsorbed to maintain the volume of water in the body. So two factors which regulate the release of ADH. Okay, in case of a central diabetes insipidus, okay, what's going to happen? The hypothalamus won't be synthesizing the ADH, so you will get the ADH deficiency in case of central diabetes insipidus. Okay, and as a result, the free water will be losing from the kidney. You will get the this more frequency of the urine. Okay, In case of a nephrogenic diabetes insipidus, what's going to happen? The V2 receptors, they will be inhibited. Okay, they will become defective, and as a result, the ADH would be there, but this ADH won't be causing the activation of these V2 receptors, and as a result, you will get the diabetes insipidus, right? And the desmopressin is the analog of the ADH, which is used for the treatment of central diabetes insipidus. This desmopressin can also be used for the differentiation of nephrogenic diabetes insipidus and the central diabetes insipidus, because whenever you give the patient desmopressin, okay, if the diabetes insipidus is improved, that means it was the central one. Okay, if the diabetes insipidus is not improved, that means it was the nephrogenic type, because the receptors are mutated in them. Okay, and another important function of this ADH is the, can anyone remember in the blood an important function of this ADH other than this aquaporins and the vasoconstriction?
Release of factor 8.
Yeah,
Von
exactly.
Willebrand's factor.
Von Willebrand factor. They also causes the increased release of von Willebrand factor, and von Willebrand factor actually causes the clotting factor 8, right? So in case of a hemophilia disease where you have a low level of this clotting factor 8, if you give the patient ADH analogs like the desmopressin, they will cause the increased release of von Willebrand factor, which will cause increased release of factor 8, right? So you will use the ADH also in the treatment of hemophilia. Okay. So, and what are the agents which can cause a nephrogenic diabetes insipidus? These are the lithium, okay, and hypercalcemia. If you guys remember from the pathology section, the hypercalcemia, whenever you have a high calcium levels, it would be deposited in the collecting duct, and where they block these channels, the V2 receptors, and as a result, patient will get the nephrogenic diabetes insipidus. Okay, so one of the symptoms of the hypercalcemia is the polyuria, very important, and the excessive thirst. Okay, similarly, this hypokalemia can also cause the nephrogenic diabetes insipidus. Okay, by blocking the the V2 receptors, very important. Lithium, hypercalcemia, and the hypokalemia, they can cause the nephrogenic diabetes insipidus. Yeah, that would be all about the ADH. Any doubt?
I have one question.
Yeah.
Like, is there any difference between collecting duct and collecting tubule?
Yeah, of course.
Like,
No,
which
the
one?
tubules. Would just give me a second. The collecting ducts are the tubules, I think. You have the DCTs, right? The distal convoluted tubules. So everything in the nephron part is the tubules itself, right?
Okay.
So these are the same, I think. Yeah, these are the same. The collecting duct and the collecting tubules are the same.
Okay. Thank you.
Okay, so not just a collecting duct, the ADH is the V2 receptors are also present in the DCT part also. Okay, in the distal DCT you can find the V2 receptors as well as in the collecting duct. In both areas you will see the V2 receptors. And one more important thing I forgot to tell you, that along with the water, these V2 receptors are also responsible for the reabsorption of the ammonia. Okay, note this fact. Sorry, not the ammonia, but the urea.
Or urea.
Urea, not the ammonia, but the urea, sorry. Okay, these V2 receptors are also responsible for the reabsorption of the urea, so that the osmolarity in the kidney could be increased, and as a result, more water would be increased. More water reabsorption would be increased, right? So urea as well as water, they will be reabsorbed by the V2 receptors, by the activation of these receptors. Okay, very important. Because if we increase the reabsorption of the urea, then what's going to happen? The osmolarity of the kidney would be increased, and when the osmolarity of the kidney would be increased, more water could be reabsorbed by the collecting ducts. Okay, very important. So, any doubt now?
I have a question.
Yeah.
So you mentioned that calcium can block the V2 receptors, right, and cause
Yes.
but what about
But
lithium and hypokalemia? So lithium we know blocks the sodium sodium transporter or something, right?
yes, they can directly block these receptors. Lithium can directly block the receptors.
Okay, and what about hypokalemia?
I'm really not sure about the hypokalemia, and what about the this mechanism of action. I'm really not sure about that, but it's a fact that I heard while my preparation, so I have written it down that hypokalemia can cause it.
Okay, thank you.
But for the hypercalcemia, it is by the metastatic calcification, okay, which causes the calcification of these distal tubules. So you will get the deactivation of these receptors. And for the lithium, it is a direct inhibitor of the V2 receptors. So yeah, not sure about the hypokalemia, but these are the two mechanisms of action of the lithium and the calciums. Yes.
Yes, sir. So when with like loop diuretics, we get like that initial release of the hyperkalemia and hypermagnesemia into the collecting ducts, right? Will
Yes.
we too, should we worry about that at all, or?
Sorry, I didn't understand. In case of loop diuretics, you are having a high calcium level and high magnesium level, you're saying.
Yeah. So would those have the downstream V2 effects, or are these more of like a central having too much
Oh,
hyper?
no, yeah. It is only for the central one. When you have too much blood levels of the calcium, then only it can cause the metastatic calcification, right?
Yeah. Thank you so much.
Okay, now then comes the prolactin. We have discussed most of the things about the prolactin. Okay, like it is synthesized. Just give me a second. Okay, so for the hypothalamus, okay, you have the dopamine. And please remember one thing, that every hormone which is synthesized by the adenohypophysis or the neurohypophysis, okay, they are all under the positive regulation by the hypothalamus, right? Whenever the hypothalamus secretes a hormone, for example, CRH or TRH or any other hormone, okay, they will always causes the increased release of hormones from the anterior pituitary as well as the posterior pituitary, right? But but the prolactin is only one hormone in the pituitary which is under the negative regulation by the hypothalamus. Okay, prolactin is the only hormone which is under the negative regulation by the hypothalamus. Rest all the hormones are under the positive regulation. So in the scenarios, okay, where you damage the pituitary stalk, for example, or damages your hypothalamus, then secretion of every other hormone will be decreased, right? But the secretion of the prolactin will be increased. Very important. Whenever you got a tumor of the hypothalamus foci or a tumor which is metastasized to this stalk, okay, so that it could block the secretion of these hormones to the anterior pituitary, every other hormone will be decreased. Okay, you will get the hyperpituitarism, but in case of the prolactin, you will get the hyperprolactinemia. It's a very important thing. Okay, so the hypothalamus releases a dopamine and the TRH. Dopamine gives the negative feedback to the prolactin release. Okay, and the TRH causes the positive feedback to the prolactin release. So whenever you have a hypothyroidism, whether it is a primary one or the secondary one, that can cause an increase in the level of TRH, that can cause the prolactin levels also rise. Right now, when the prolactin is released, it will go to the breast. It can cause the secretion of the milk, right? Not the release of the milk, but the secretion. Sorry, but this production of the milk, right? Not the release, but the production only. That the release is by the oxytocin and the production is by the prolactin. Okay. Estrogen is a positive regulator of the prolactin. Whenever the estrogen levels become high in the body, they will increase the release of prolactin. For example, say the pregnancy. In the pregnancy, estrogen is responsible for the release of prolactin. Okay. But if you remember, even though you have a high prolactin level in the pregnancy, that do not causes the release of milk or the production of the milk. Can anyone tell me why? Even though you have
Progesterone block.
yeah, it is a progesterone which blocks the receptors for the prolactin, right? So that's why in case of pregnancy you have a high prolactin levels, but even after having the high prolactin level, that it won't cause the milk production because of the presence of this progesterone, okay, which blocks the receptors of the prolactin, right? So prolactin, so this estrogen causes the increased release of prolactin, and in response, the prolactin inhibit the release of GnRH. Okay, and as a result, the FSH and LH would be decreased. Okay, whenever you have a renal failure, in case of a renal failure, you cannot excrete this hormone from the body, and as a result, the level of the prolactin will be rise in case of chronic kidney disease. Okay, prolactin also causes the positive release of dopamine. Very important. Prolactin also causes the increased release of dopamine, which inhibit the release of prolactin. So as a result, it is giving a negative feedback to itself, indirect negative feedback. Okay. Okay. And the medications, like all the medications which inhibit the dopamine receptors, can anyone tell me which medications are used for the dopamine inhibition?
Antipsychotics.
Antipsychotics, yes. Yes. Okay, so these are the medications which can inhibit the dopamine. They can cause an increased release of prolactin, and that's why the gynecomastia in the males and galactoria in the females. Any chest wall injury, okay, whenever whenever you have a chest wall injury, they have an autonomic sympathetic system activation that can cause the inhibition of the dopamine, right? Nipple stimulation after the pregnancy can cause the inhibition of the dopamine, so that the milk could be produced. Okay. Whenever the baby is cried, okay, higher centers will be activated, which inhibit the hypothalamus. And by inhibiting the hypothalamus, they inhibit the release of dopamine, which can cause the increased release of prolactin. Okay, very important. So yeah, that would be all about the prolactin. Let's discuss what the FS is. So they are secreted by the anterior pituitary, okay, stimulate the milk production in the breast and inhibit the ovulation in the females and spermatogenesis in the males by inhibiting the GnRH. Okay, excessive amount of this prolactin is associated with the decreased libido as well as the loss of the hormone synthesis, and you can get the hypogonadism, right? Regulation, it is secreted by the anterior pituitary and it is inhibited by the dopamine. Okay, and the pathway, please remember the pathway name, which is the tubo-infundibular pathway. By the tubo-infundibular pathway, the dopamine inhibit the release of prolactin. Okay, and in response to the increased release of this hormone, it also causes the increased release of dopamine, which inhibit its release. Okay, so it is kind of giving the negative feedback to itself, right? The TRH, it also causes the increased release of prolactin. Okay, so in case of a primary or a secondary hypothyroidism, you can get a high TRH levels. The dopamine agonist like bromocriptine, they're actually useful for the treatment of gynecomastia or the this galactoria. Okay, dopamine antagonist, which are most of the time antipsychotic drugs, or the metoclopramide. Can anyone tell me the use of metoclopramide?
Antiemetic.
Yes, antiemetic. And one more area, gastroparesis. Okay. So whenever you use these medications, they can also cause the gynecomastia. Estrogen therapies, because the estrogen will be released. Estrogen will causes the release of prolactin. Okay, so OCP therapies or the pregnancy, they will stimulate the prolactin synthesis. Okay. Any doubt about prolactin?
Oh no.
So whenever you have a pituitary adenoma, and the most common type of adenoma in the pituitary is a prolactinoma. Okay, so in case of a prolactinoma, you will have a decreased libido. You will have an early menopause. Why? Because of inhibition of the estrogen and inhibition of LH and FSH. Okay, you will get the amenorrhea, oligomenorrhea. Galactoria will be seen because of increased prolactin level that can cause the increased release of milk. Okay, bone density will be reduced. Why? Because estrogen is responsible for the osteoblast activation, right? So bone formation will be inhibited. You will get the decreased bone density or the osteoporosis. Okay, and of course it will decrease the release of estrogen. Okay, and like we have discussed, every hormone which is released by the hypothalamus, it will cause the increased release of hormones from the pituitary. But the prolactin is the only hormone which is under the negative regulation by the hypothalamus. So any tumor or kind of a trauma or any disease which causes the inhibition of the hypothalamus or destroy this stalk, the pituitary hypothalamus stalk, okay, it will cause the hypopituitarism. Okay, but in case of the prolactin, it will cause the hyperprolactinemia, right? Very important. So for any destruction of the hypothalamus pituitary disruption, it will cause the hypopituitarism, but in case of prolactin, it will cause the hypoprolactinemia. Step 1 will ask you this fact. They will tell you a certain scenario like a tumor or a trauma case where they will tell you that a tumor is metastasized to this stalk, and they will ask you what hormone could be increased and what hormone could be decreased. So please remember this fact. Okay. In case of neurosarcoidosis, okay, whenever you have a neurosarcoidosis, it will involve the hypothalamus and it will cause the hypopituitarism, but they will cause the high prolactin levels also, right? So any doubts so far?
No.
Okay. Then comes the thyroid hormone synthesis.
One question, please.
Sure.
So if the baby cries, it will decrease the prolactin production, if I understand
Yes.
it correctly.
But if the baby cries, it will increase the prolactin production.
Okay, because the picture showed like that. Okay, thank you.
See, the picture actually showing
because the higher cortical receptors
this cry of the baby will stimulate the other centers, higher centers, which inhibit the hypothalamus. So hypothalamus cannot release a dopamine, right?
Okay. Got it. Okay, thank you.
Okay, and dopamine inhibits the release of prolactin. Okay.
Yes, thank you.
Just give me a second. And in the pregnancy, you have the high estrogen levels, which causes the increased release of prolactin. But even though the high prolactin levels are present, they cannot stimulate the milk production. Why? Because of the presence of progesterone. Okay, very important. The hormone is responsible for the blockage of prolactin receptors. Okay, the progesterone.
Yes, thank you.
Okay, now comes the thyroid hormones. You have two thyroid hormones, the triiodothyronine and the tetraiodothyronine or the thyroxine. Okay, first you need to know how these hormones are synthesized in the thyroid gland. Okay, so from the diet, in the diet you will take the tyrosine. Okay, the tyrosine will be taken up by these thyroid follicular cells. Okay, in the diet you also take the sodium as well as the iodine. Okay, in the thyroid follicular cells you have the symporters, the sodium iodine symporters, right? The sodium iodine symporters will take up the sodium as well as the iodine in the ionized form. Okay, when the iodine enters into the thyroid cells in the thyroid follicular cells, what's going to happen? This iodine will be oxidized. Okay, and it is combined into form the molecular form, which is the I2, right? And it is done by the enzyme known as the thyroid peroxidase. So first step is the take up of the iodine, okay? And the iodine will be converted to the I2 form or the molecular form by the thyroid peroxidase. You also take the tyrosine, okay? And this tyrosine will be binded to a protein known as the thyroglobulin, which is already present in the thyroid follicular cells. Now this the tyrosine will be binded to the thyroglobulin, okay? So this is the TG, and this tyrosine will be binded to it, as you can see here, right? Now comes the step of the organification. In the organification, you will combine the iodine with the tyrosine residues on this thyroglobulin, okay? And this step is also, stimulated by the enzyme known as the thyroid peroxidase. Okay, so after the organification, either one molecule of iodine or two molecules of this iodine will be binded to the tyrosine, and now it is known as the monoiodotyrosine or the diiodotyrosine. Okay, either the one iodine or the two iodine will be binded to the tyrosine, now known as the MIT or the DIT, right? Now, after the organification step, the coupling reaction will occur. In the coupling reaction, again, this enzyme, the thyroid peroxidase, it will combine the MIT and DIT, okay, to form the T3, which is the DIT with the MIT. Okay, it will form the T3. Okay, and the DIT together, it will form the T4. Okay, so MIT with DIT form the T3, and DIT with DIT forms the T4, right? And note the one fact that in the thyroid, T4 is formed in much more amount than the T3. T3 is the activated form, although, okay, T3 is the activated form, but T4 is synthesized more than the T3, because the body can store, or the thyroid gland can store this T4 form easily, right? So in the thyroid, the T4 will be secreted more than the T3. Now this endocytosis step will happen, and yeah, all of these steps will be in the follicular lumen. Okay, if I draw the diagram, and this is the thyroid follicle, let's say. Okay, and these are the cells around it, right? These are the follicular cells, right? And in the center of them, there is a lumen. Okay, these are the blood vessels. From the blood vessels, iodine will be taken in the follicle cells. Okay, and the tyrosine will be taken in the follicular cells. The tyrosine will be combined to a thyroglobulin, and this combination, the thyroglobulin with the tyrosine, is known as the colloid material. So whenever you hear the word the colloid in the thyroid, okay, this colloid is actually the thyroglobulin along with the tyrosine. Okay, very important. So this is a colloid present. Now the iodine will be converted to the I2 form, right? It would be first combined with these tyrosine molecules to form the monoiodotyrone and the diiodotyrone, okay, tyrosine, to form the MIT and DIT. After that, coupling reaction will occur. Finally, the endocytosis again happen within the cells, okay, and from there they will be released in the blood circulation, okay. And again, in the blood circulation, the T4 is higher than the T3 because T4 can be easily stored, right? At the tissue side, this T4 must be converted to the activated form, which is the T3, okay. And it is happened by the enzyme. Two enzymes are actually available. One is the 5-deiodinase and the 5-deiodinase, okay. And you need to know the difference between them, okay. Just give me a second. Yeah. Okay, so this T4 will be converted to the T3 by the action of the enzyme 5-deiodinase. Okay, and if the 5-deiodinase enzyme, work on the T4, then it will convert the T4 into the reverse T3, which is the inactivated form. Okay, so if the 5-deiodinase work on the T4, it will convert the T4 into the activated form T3. Okay, if only the 5-deiodinase, not the 5-deiodinase, if 5-deiodinase work on the T4, it will convert the T4 into the deactivated form, which is the reverse T3. Okay, very important. Okay, so that's how the synthesis of the T3 and the T4 will occur. Okay, and in the peripheral tissues, the T4 will be converted into the T3, and then they will do the further functions in the cells, right? And now you need to know the release, and under what circumstances this T3 and T4 will be released. So first, the hypothalamus will secrete the TRH. Okay, the TRH will go to the anterior pituitary. In the anterior pituitary, it will synthesize the TSH. Okay, the TSH will go to the thyroid follicular cells. Okay, and it is the TSH which is responsible for the secretion of the thyroglobulin. Very important. The TSH is responsible for the secretion of thyroglobulin. So whenever the step 1 says, the stem of the question says that the patient is having a high colloid, okay, then please remember the high colloid is only because of the increased release of TSH. Whenever you have a high TSH level, you will have a high colloid in the thyroid follicles. And that's why the size of the gland will be increased, right? Very important. So if I say the drugs like the drug, the PTU or the methimazole, okay, whenever you give the patient these drugs, what's going to happen? They will inhibit the every step of the formation. This step, the oxidation step, the organification step, and the coupling reaction, all will be inhibited by the PTU or the methimazole, but they do not decrease the colloid. Very important, they do not decrease the colloid. Step 1 will ask you this thing about the colloid. What will happen with the colloid material? So these drugs, they do not decrease the colloid, okay, because they're under the direct stimulation of the TSH, right? Not under the thyroid peroxidase. Very important. Then the TSH, when act on these cells, it will cause the increased secretion of the thyroglobulin and as well as increased release of the T3 and T4. The T3 and T4 will be go to the effector organs where they will cause the effect. Okay. The T3 and T4, they also give some negative feedback to the hypothalamus as well as the pituitary. Very important. And because the T4 is in higher amount than the T3, it will give more negative feedback than the T3. Okay. Somatostatins, they are, they can directly inhibit the release of TSH from the pituitary. Okay. And yeah, that would be all. Now you need to know about the functions of the this thyroid hormone. Okay, what functions does thyroid hormone play in your body? Very important to know. Okay, so first it will cause the brain maturation. Okay, second thing, it will cause the bone growth. Okay, which is a synergistic action with the growth hormone. They have the synergistic hormone, synergistic actions, like, or okay, and at the low levels, okay, very important, at the physiologic levels or at the low levels, this thyroid hormone which stimulates the osteoblast cells and can cause the bone growth. But at a high levels, like in case of like in case of a hyperthyroidism, it actually causes the activation of osteoclasts. Very important, at the physiologic levels, it causes the activation of osteoblast, and that can cause a bone growth. Okay, at a very high levels, they will activate the osteoclast, so you will get the bone resorption or the osteoporosis at in case of hyperthyroidism. Okay, and they will also stimulate the beta 1 receptors which are found in heart and in the kidneys, so they can cause an increased cardiac output, increase heart rate, increase stroke volume, increase contractility. And that's why whenever you have a symptoms with the hyperthyroidism, or you can say the thyroid storm, you will always give the patient beta blockers first. Okay, to inhibit all the symptoms. Okay, for the symptomatic relief, you will always give the patient beta blockers because all the symptoms of the hyperthyroidism are because of beta 1 stimulation, the anxiety, the chest pounding or a high heart rate, okay, and the sweating and this high BP, all of these are due to the beta receptors, right? Uh, this thyroid gland can also increase the basal metabolic rate, okay, and that's why it will increase the oxygen consumption. It can cause the weight loss. Okay, that's why in case of hyperthyroidism, you will get the weight loss because it will increase the metabolic rate. Along with the weight loss, it can also increase the body temperature. Okay, that's why you get a high body temperature in case of hyperthyroidism and low body temperature in case of hypothyroidism. It will also increase the blood sugar level. Okay, it can cause the hyperglycemia by increasing the glycogenolysis, which means the breakdown of glycogen, and the gluconeogenesis, which means the synthesis of glucose. Okay, it will also cause the breakdown of the lipids, so it can cause the lipolysis, just like the growth hormone things. Okay, growth hormone can also increase the high glucose levels and can also cause a lipolysis. Similarly, can also cause the high glucose. Okay, and in lungs, this thyroid is also stimulates the release of surfactants. Very important. In lungs, thyroid hormone also release the surfactant. Okay, very important to cause a lung maturation, right? So very important for the lung maturation also. Regulation we have discussed already. Okay, in case of TRS, they will cause a TSS release, which will stimulate which will stimulate the follicular cells, right? And yeah, in case of Graves' disease, what's gonna happen? You have the antibodies which mimic the TSH. Okay, you have the antibodies which mimic the TSH. They will activate the TSH receptors found on this follicular epithelium to increase the to increase the synthesis of thyroglobulin and as well as the T3 and T4. And that's why in case of Graves' disease, which is an autoimmune condition, you can have the hyperthyroidism, right? Because of the thyroid stimulating hormone like antibodies. Okay, negative feedback will be given to both the hypothalamus as well as the anterior pituitary, right? And one more thing, whenever you have a high estrogen level, okay, high estrogen levels can increase the protein bindings to the hormone, to the other hormones or to the other proteins or to the carrier proteins, I must say. Whenever you have a high estrogen levels, they will increase the carrier protein level in the blood. Okay, and the carrier protein in the blood is increased, which is a thyroxine binding globulin, TBG. Do not confuse it with the thyroglobulin. Thyroglobulin is found only in the follicular cells and the lumen. Okay, and in case of blood, okay, all of these T3 and T4 will be traveled by the thyroxine binding globulin or the TBG. Okay, and whenever the T3 and T4 bind it to the TBG, they will become inactivated. Okay, only the free T3 and T4 is the activated ones. Okay, binded T3 and T4s are not activated. Okay, so whenever you have a high estrogen levels, like in case of pregnancy or the OCPUs, the thyroid binding globulin levels will be increased, and as a result, you will get the total increase in T3, T4. But because now the free levels of T3, T4 will be decreased, what gonna happen? They will give the positive feedback because of low level of T3, T4. They will stimulate the anterior pituitary and the hypothalamus to secrete more TRH and the TSH. So more T3, T4 will be released, right? So ultimately, you will get the increase in the total T3 and T4 levels, okay, and a low T3, T4 in the initial stages, and in the later stages, you will get the normal T3 and T4 free. Okay, very important. And whenever you have a nephrotic syndrome, because in case of nephrotic syndrome, what's going to happen? You are actually losing the proteins from the body, okay, and from the protein is the thyroid binding globulin. So you will have a low thyroid binding globulin levels in the nephrotic syndrome. Okay. Similarly, in case of steroid use, you will have a suppression of the natural release of this estrogen. So you will get a low level of thyroxine binding globulin also. Okay. So any doubt on the thyroid hormone and their functions?
Could you please explain the cause of steroids decreasing the thyroid binding globulin?
If you give the patient external steroids and the the natural LH and FSH will be decreased, right? And when the LH and FSH is decreased, what's going to happen to my estrogen levels? They will also fall, right? And when the estrogen levels are falling, what's going to happen to the TBG level? They will also fall, right? Along with that.
Yeah.
That's why you get the low TBG levels.
Yeah, thank you.
See, the steroid here is not the estrogen, right? I think you might be confusing the steroids with the estrogen, but estrogen therapy is different and steroid use are different, okay?
Yeah.
When you use the steroids like the cortisol in case, okay, it will inhibit the estrogen, right? Different things. So first thing, you need to know the name of the hormone. Second thing, how they are synthesized. Third thing, the control of these hormones. Fourth thing, the function. And fifth thing, the fourth thing only is right. And one important thing, which is the Wolff-Chaikoff defect. Okay, whenever you have an excess iodine in the body, see, iodine is responsible for the synthesis of the T3 and T4. But if you have an excess of the iodine in the body, then in that case, you're actually having the inhibition of the thyroid peroxidase. And remember, this enzyme is responsible for the oxidation, okay, for the organification and for the coupling step, right? So all of the three steps would be inhibited and you will get the low level of T3 and T4. Very important. This is the Wolff-Chaikoff defect. So it is a kind of a treatment for the hypothyroidism also. In case of a hyperthyroidism, if you give the patient too much iodine, in that case, you can have the inhibition of this hyperthyroidism, okay? A treatment kind of.
Yeah, Dr. Chaudhary, one
Yeah.
you mentioned in the estrogen, right? Increased T3, T4, and then you also said something about early phase and late phase. Can you
See,
explain that?
let's say you have, let's say you're just started the OCP therapy, okay? When you take the OCP therapy or the estrogen, what's going to happen to my TBG level? It will be increased. And when the thyroid binding levels will be increased, they will bound to more T3 and T4. And as a result, the free T3, T4 level will be decreased and the bounded one will be increased. Now, when the T3 and T4 level will be decreased, they will give the negative feedback to the anterior pituitary and the hypothalamus so that more TRH and TSH will be increased, release will be increased. And as a result, the T3, T4 production will also be increased, right?
Mm-hmm.
So initial stages, you will get the low level of free T3 and T4, but later on, because of the compensatory mechanism, you will get an increased total T3 and T4, which is the free as well as the bounded level, and a normal free T3 and T4. Okay.
Okay.
So if I step one gives you a certain scenario in which you are having a total, in which you're having an increased level of total T3 and T4, okay, but a normal level of these free T3 and T4 or a normal TSH, I must say, because whenever the free T3 and T4 is normal, then you have a normal TSH. So whenever step one give you a certain scenario in which you are having a high total T3 and T4 and a normal TSH, not increased, not decreased, but a normal TSH, that means it is a case of increased this thyroxine binding globulin. It is because of this increased TBG levels, which could be due to pregnancy, could be due to the OCP use. Okay. Very important. Any more doubt on this page?
Did you say that there are two types of deiodinase? I did not get that. Which did you say?
See, you have two type of enzymes. One is the 5' deiodinase and a 5-deiodinase. Okay, When the 5' deiodinase work on the T4, it will convert the T4 into the activated T3, right? But when you have the 5-deiodinase, it will act on the T4 to convert it into the reverse T3, which is the metabolically inactivated byproduct.
Okay, thank you so much.
Okay, two things. And yeah, glucocorticoids will inhibit it, beta blockers will inhibit the receptors, propylthiouracil will inhibit the two things. One is the enzyme, that thyroid peroxidase, and second is the 5-deiodinase. It is by the PTU. The beta blockers, they also inhibit the conversion of this T4 into the active T3. And similarly, the glucocorticoids or the cortisol, I must say, they also inhibit the conversion of T4 into the T3 by inhibiting the enzyme 5-deiodinase. So glucocorticoids, beta blockers, as well as PTU, these three drugs actually inhibit the conversion of T4 to T3. Okay, and the drug like PTU and the methimazole, they inhibit the enzyme thyroid peroxidase to inhibit the synthesis of the T3 and T4. So please remember what drugs are inhibiting the synthesis and what drugs are inhibiting the this conversion. 3 drugs for the conversion and rest all on the synthesis. Okay. Any more doubts?
I actually had one question.
Yeah, do I?
When it says here that cortisol or steroids are going to decrease my thyroid production, right? My thyroid hormone production.
Yes.
Okay. But it also says that it increases the surfactant in babies.
Yes.
But doesn't cortisol?
See, both are responsible. See, thyroid are also responsible. Steroids are also responsible. Okay, they have both the different mechanisms, right? And most important ones for the synthesis of the surfactant are the steroids, not the thyroid. Thyroid has the action, but a minor action. Okay, not the major one.
Okay, so the fact that steroids would downregulate a little bit, okay, so that's not important enough to detect.
Yeah, exactly. Yeah, exactly.
Oh, cool. Thank you.
Okay, so and from these functions of the thyroid, you can easily know what symptoms you're gonna get in the hypothyroidism and what symptoms you're gonna get in the hyperthyroidism. Whenever you have the hypothyroidism, the brain maturation will be inhibited, right? And this is the most feared thing. Okay, and because of this brain maturation function of the thyroid, you always want to give the patient, the baby, supplements of the thyroid as soon as possible whenever you detect a case of hypothyroidism, right? Because of this brain maturation. So step 1 will ask you that why you are giving the patient therapy, a baby, a neonatal therapy of this thyroid hormones. Okay, it is to prevent the brain maturation. They will give you some, some other also, like to prevent the goiter, or to prevent other scenarios. And the most important thing is the brain maturation, not the goiter. Okay, although it can also cause a goiter, but the most important thing for which you give the patient supplements of the thyroid, it is because of the brain maturation function of the thyroid hormone, right? Do remember this thing. Okay, we can take a short break of 10 minutes, then we will meet again and we will start the parathyroid hormone, okay?
Okay.
Okay, 2 sets of glands are present just posterior to the thyroid, okay? The upper ones and the lower ones. And these glands are derived from which structure? Anyone?
Third and fourth pharyngeal pouches.
Third and fourth pharyngeal pouches. Third pharyngeal pouch actually forms the lower ones, okay? And the fourth pharyngeal this pouch forms the upper ones, upper two, okay? Very important. Now, in the parathyroid gland, you have these chief cells. Very important. Chief cells are not just found in the GI tract, in the stomach, but also the parathyroid gland have the chief cells, okay? Please remember this fact. I think it is a question from the NBMEs, not the question from the NBMEs, and they have asked the location of the synthesis of the hormone in the parathyroid gland, and it was the chief cells. Very important. Okay, so chief cells are secreted are synthesizing the parathyroid hormone from the parathyroid gland. Okay, what is the function? The ultimate function of the parathyroid hormone is to maintain the blood calcium levels. They will increase the blood calcium levels. Okay, so whenever the blood calcium level dropped, only then the parathyroid hormone will become activated, and after activation, it will leads to an increase in the blood calcium level. Okay, and how does it gonna do that? See, whenever the parathyroid hormone released in the circulation, first thing it will activate the 1-alpha hydroxylase. Very important, it will activate the 1-alpha hydroxylase. And does anyone remember the location of this 1-alpha hydroxylase?
Proximal to you.
In the
Proximal
PCT of, yeah, in the PCT of the kidneys. Okay, and this 25 hydroxy vitamin D3, which is a stored form in your body, it will be activated to the 1,25 dihydroxy vitamin D3. Okay, 125 dihydroxy vitamin D3. It is by the enzyme 1-alpha hydroxylase, which is in the PCT. Okay, and via this vitamin D3, okay, it will cause the reabsorption of the calcium in the kidneys, as well as the absorption of the the phosphate and the calcium from the GI tract. Very important. It will increase the absorption of calcium and phosphate in the GI tract, as well as the reabsorption of the calcium in the kidneys. Okay. Second thing is, after the activation of the vitamin D3, very increased vitamin D3 levels can also cause the bone resorption, and from the bone it will release the calcium and the phosphate. So one part of the action is the activation of vitamin D3. Vitamin D3 will go to the kidneys, where it will increase the reabsorption of the calcium and of the calcium only. In the GI tract, it will cause the absorption of the calcium and phosphate. Okay, in the bone, it will cause the resorption. Okay, first part. Second part, this parathyroid hormone can directly activate the osteoblast cells, and osteoblast cells then activate the osteoclast cells. Very important. Parathyroid hormone initially activate the osteoblast cells. Okay, and then osteoblast cells will activate the osteoclast cells to cause the bone resorption. Again, it will release the calcium and phosphate from the bone, so that the blood calcium and phosphate level would be increased. Okay, then this PTH will go to the kidney, and from the kidney it will cause the increased reabsorption of the calcium and increase excretion of the phosphate. Very important. In kidney, the parathyroid hormone will cause the increased reabsorption of the calcium and increase excretion of the phosphate, and as a result, in the urine the calcium level will be dropped and phosphate level would be raised. But in blood, ultimately the calcium level will be increased and phosphate level will be decreased. This increase in the calcium level will also give a negative feedback to the PTH release, as well as the activated vitamin D3. It will also gives the negative feedback to the parathyroid glands to inhibit the release of parathyroid hormone. Okay, so for the function, it will cause the increased calcium and phosphate absorption from the GI tract. Okay, it will cause the increased calcium and phosphate release from the bone. It will cause the increased calcium reabsorption in the DCT. Very important. The location is very important. DCT it is for the calcium reabsorption. For the phosphate excretion, it is by the PCT, because PCT is responsible for almost 70 or 80% of the phosphate. Okay, so it will be inhibited in the PCT. Okay, the activated vitamin D3, which is by the 1-alpha hydroxylase, it is also done in the PCT. So in the PCT, two things are happening. One is the activation of vitamin D3, and second is the excretion of the phosphate. In the DCT, reabsorption of the calcium is happening. Okay, very important. And you also must remember the transmission of the signals from the parathyroid hormone. It is by the cyclic AMP. Parathyroid hormone works by the cyclic AMP. So whenever you have a high parathyroid hormone levels, you always have the high cyclic AMP levels. Okay, and it could be detected in the urine. So whenever you have a high urine cyclic AMP levels, that means the parathyroid hormone levels will be high in your body. Okay, and whenever you have a high parathyroid hormone level, they will increase the calcium, they will decrease the phosphate, and they will increase the phosphate in the urine. Okay, very important. And for the bones, like we have discussed, they will first activate the osteoblast cells, and the osteoblast cells will activate will increase the rank ligand, which is the receptor activator of NF kappa B, or the nuclear factor kappa B ligand. Okay, receptor activator of NF kappa B ligand. Okay, this rank ligand will bind to the rank receptors which are present on the osteoclast. so that the osteoclast can be activated. Okay, so first the osteoblast cells activation, then the osteoclast cells activation. Now you must also know one fact that at a low levels or in a pulsatile manner, whenever the PTH is secreted in the pulsatile manner, it will cause the bone formation. Okay, so whenever the PTH is released in the intermittent manner or the PTH is released in the pulsatile manner, it will cause the bone formation, and that is the function of the teriparatide. Teriparatide is the analog of the PTH. Okay, it is given in the pulsatile manner to cause the bone formation. But whenever the PTH is synthesized continuously or in a high levels, it will cause the bone resorption. So bone formation at pulsatile manner and bone resorption at continuous or a high levels. Very important. Then you have certain tumors, and these tumors can release the parathyroid hormone-like peptides or PTH-related peptides. Okay, you must remember the name of the cancer, which are the renal cell carcinoma and the lung cancer, squamous cell carcinoma of the lung, and the RCC. Very important. These two tumors can release the parathormone-related peptide, and that can cause the hyperparathyroidism. Okay, can cause the hypercalcemia, but it is not a true PTH. It is the PTH-like peptide. Very important. Some tumors can directly activate the vitamin D3, and by the action of vitamin D3, they can cause the increased level of calcium. For example, the granuloma, like we have discussed, in the granuloma, the macrophages will activate the 1,alpha hydroxylase. Similarly, in case of sarcoidosis, okay, you can have a high activity of 1-alpha hydroxylase in the macrophages that can cause the high vitamin D3 activation. Some tumors can directly metastasize to the bone, and in the bone, they can activate the osteoclast cells by secreting some cytokines. For example, the multiple myeloma, okay, it will directly causes the bone resorption. So remember, please remember the different type of tumors which causes the high calcium level by different mechanisms. Staff bank will ask you this. Okay, they will give you a certain tumor name, and they will ask you the reason behind the hypercalcemia in this tumor, right? So you must remember. Then the regulation, whenever you have a low calcium level, it will activate the PTH secretion. Whenever you have a high phosphate level, because one of the function of the parathyroid hormone is to decrease the phosphate levels also. So hyperphosphatemia can activate the parathyroid hormone. Similarly, low level of magnesium will activate the PTH, but very low level of magnesium can inhibit the PTH secretion. Okay, and the common cause of loss of magnesium, it includes the diarrhea, aminoglycosides, diuretics, and alcohol abuse. And can anyone remember any other drug which can cause hypomagnesemia from the microbiology?
Amphotericin.
Antiviral drug.
Yeah. What drug?
Like there was a drug, acyclovir like drug.
Not the acyclovir. Acyclovir can cause the stone formation, but not the loss of these
Amphotericin.
ions. Amphotericin B, yes. Amphotericin B can cause the low level of magnesium. And any other drug other than amphotericin B? Any antiviral drug? We have discussed that. No? Antiviral drug? Yeah. What drug?
Is it trimethoprim?
Not the trimethoprim. Antiviral.
Or is it
Remember
one
the
of the
foscarnet, which has an activity on the viral DNA, viral RNA polymerase, reverse transcriptase. Remember the foscarnet drug, which inhibit the DNA polymerase, RNA polymerase, and the reverse transcriptase of the virus, which is used in the resistance cases of gencyclovir resistance, in the CMV and other cases. Remember? Cidofovir can cause it can cause a protein urea, but not the loss of ions. It is foscarnet which can cause the hypomagnesemia, hypocalcemia, as well as the hypokalemia. Okay, and amphotericin B similarly can cause the hypomagnesemia and hypokalemia, right? So please remember these drug name, very important. Okay, don't forget the names. Foscarnet is a special agent. It can inhibit the DNA polymerase, RNA polymerase, as well as the reverse transcriptase. And mostly you use this drug for the treatment resistance CMV infections or treatment resistant HSV infections. Okay, so don't forget that.
So would those drugs cause would they cause increased PTH or decreased PTH?
They will cause
Decreased
initially if the if low levels of magnesium are there, then they will cause the increased PTH. But if you give them in a very high amount, like in case of toxicity, then they will cause a low release of this PTH. Okay, after that, initially increase and decrease.
Thank you.
Okay, so whenever you have a low vitamin D levels, they will cause the bone mineralization. Whenever you have a vitamin D3 in excess, it can cause the bone resorption. Similarly, whenever you have a physiological or low levels of PTH hormone or a pulsatile secretion of the PTH hormone, it can cause the bone formation, which is the reason why you give the patient teriparatide for the bone formation, which is a PTH analog. But if you give a high level of PTH or a continuous PTH is there in the body, it can cause a bone resorption. Very important. Any doubt on this parathyroid level?
Why does multiple myeloma, how was multiple myeloma associated with parathyroid hormone?
Multiple myeloma can cause the hypercalcemia, right?
Just because of the
Because
amyloidosis, right?
it is a tumor of bone, remember, bone marrow tumor it is, multiple myeloma. So it will raise the cytokines that can activate the osteoclast directly, right? And that will cause the bone resorption. So it can cause the hypercalcemia.
Oh,
So
okay.
when hypercalcemia is there, it can inhibit the this release of hormone, the PTH, right? Low level of PTH.
That makes sense. Thank you.
Okay. Now comes the calcium homeostasis, very important. Just give me a second. Okay. Now comes the calcium homeostasis. For that, you must remember that three forms of calcium exist. Okay. One is the ionized form. And whenever any hormone or any ion is in the free form, okay, it is the activated form of the hormone or the ion. Very important. Okay. And this is the form which is responsible for the positive feedback or the negative feedback or any function in our body, right? So for any hormone to be functional, to be active, it must be in the free form, right? Similar for the calcium. Whenever it is ionized or free, it is the activated form. Second form is bounded to the albumin, okay? And third form, it is bound to the anions like phosphate, okay? Calcium phosphate, if you guys remember the molecule, right? So whenever you have a high pH, very important, whenever you have a high pH or the less hydrogen ions, which you can say metabolic alkalosis or the respiratory alkalosis, albumin will bind more to the calcium. And as a result, the free calcium, or I can say the ionized calcium level will be dropped. And as a result, you can get the symptoms of the hypocalcemia. Okay, very important in case of any alkalosis, which is metabolic or respiratory. Okay, more albumin can bind to the calcium, and as a result, it can cause the hypocalcemia. Further, it can activate the parathyroid hormone level. So, an easy way to remember is high pH for high PTH, low pH for low PTH. Okay, and it is because of the binding of the albumin to the calcium. Whenever you have a low calcium level, the sodium channels can activate too much, because if you guys remember, the calcium is an inhibitor of the sodium channels, right? So now the sodium channels can activate too much, and as a result, it can cause the cramps, hyperreflexia, paresthesis, okay, and the pain, of course, right? Similarly, in case of low pH, less albumin will bind to the calcium, that can cause the increased ionized calcium levels or the hypercalcemia like symptoms. You will have a low PTH levels. Okay, very important. So only free calcium levels are responsible for the regulation of the PTH. Okay, not the albumins. Okay, and yeah, that would be it. Then comes the hormone, which is the calcitonin, which is released by the parafollicular C cells. Very important, and it function opposite to that of parathyroid, the PTH hormone. Okay, it function opposite to the PTH. Why? Because it decreases the bone resorption. It decreases the calcium levels in the blood. Okay, whenever the calcium level in the blood is increased, this hormone will be released by the parafollicular C cells. Okay, and it will cause the decreased serum calcium levels. Okay, and nothing much about the calcitonin, just opposite action of the PTH. Okay, and it is kind of not very much important for the normal calcium homeostasis. PTH is the major one, right? Very important. Then comes glucagon. Okay, and glucagon is released by the alpha cells of the pancreas. Which cells of the pancreas releases the insulin?
Beta.
cells.
Beta cells, and alpha cells releases the glucagon. Okay, the function of the glucagon is mainly on the liver. Okay, on the liver it can cause a glycogenolysis. Okay, which is the breakdown of the glycogen to form the glucose. Second is the gluconeogenesis, which is a formation of glucose from other substrates. Third thing is the lipolysis. Okay, fourth thing is the ketogenesis. Okay, all of these things are by the action of glucagon on the liver. Okay, so ultimately it will maintain the high glucose level in the fasting state. Okay, very important. For the regulation, it is only activated or secreted in response to the hypoglycemia. Okay, and whenever the glucagon is secreted, okay, it will always increase the secretion of insulin, and in return the insulin will inhibit the secretion of glucagon. Very important. Glucagon increase the release of insulin, and whenever the insulin is released, it will inhibit the release of glucagon. Okay, hyperglycemia will inhibit the glucagon. Somatostatins will inhibit the glucagon. Okay, so in case of hypoglycemia, whenever there is a patient who is having a history of diabetes and taking some insulin injections, and he suddenly get the hypoglycemic episode. Okay, the fastest way to relieve the hypoglycemia, other than giving the patient glucose, of course, directly, it would be the glucagon injections. Very important. So diabetes patient, they always carry the glucagon injection in case if they get the hypoglycemic episode. So this glucagon can directly activate the these pathways so that the blood glucose levels can be can return to the normal. Okay, so let's discuss how some hormones or some neurotransmitters can maintain your normal glucose level in case of fasting. Okay, so first we have discussed the function of glucagon, which is mainly on the liver, and on the adipose tissue it causes the lipolysis. Okay, on heart we have discussed that heart has a special receptors for the glucagon, which just like the beta 1 receptors work through the cyclic AMP, can cause the increased heart rate, increased contractility. Right now, for the epinephrine, the major action of the epinephrine is in the peripheral tissues. Okay, in the peripheral tissues, this epinephrine can decrease the uptake of glucose. First thing. Second thing, just okay. So for the central part, it is a glucagon. For the peripheral part, it is the epinephrine. Okay, epinephrine causes the adipose tissue. In case of adipose tissue, it will cause the lipolysis. Okay, from the kidney, if you guys remember that not only the liver but also the kidney is also responsible for the gluconeogenesis. Okay, so the gluconeogenesis from the kidney is the responsibility of epinephrine. Okay, very important. So two things: the release of the free fatty acids and the gluconeogenesis by the kidney, and the decrease intake of the glucose by the muscles and this adipose tissues. Three function is for the epinephrine, and the major function of the glucagon is on the liver and on the adipose tissue. Okay, very important. Any doubt on this page?
Can you explain the function of epinephrine once again?
See, you have the liver and you have the peripheral tissues. Okay, glucagon action is mainly on the liver. In the liver, it can increase the release of glucose. First thing, on the peripheral tissues like the adipose tissue, glucagon will increase the release of free fatty acids or the lipolysis, I must say. Okay, why? Because glucagon can activate the hormone sensitive lipase, and that's why this enzyme name is hormone sensitive lipase, because it responds to the glucagon, which is a hormone, right? In case of epinephrine, the major function of the epinephrine is on the peripheral tissues. Okay, like for the adipose tissue, okay, this epinephrine can cause a lipolysis. First thing. Second thing, the function of epinephrine is to decrease the uptake of the glucose. Okay, the peripheral uptake of the glucose will be inhibited by the epinephrine. Second function. Third function, in case of gluconeogenesis, the epinephrine will act on the kidney to causes the renal gluconeogenesis. Very important. Okay, So for the liver gluconeogenesis, it would be glucagon. For the renal gluconeogenesis, it would be epinephrine. Okay, for the lipolysis or the activation of hormone-sensitive lipase, it would be both epinephrine as well as a glucagon. For the increased resistance of glucose to the cell, it would be the epinephrine, which decreases the uptake of glucose by the cells. So ultimately, both the epinephrine and the glucagon, they're increasing the level of glucose in the body, causing the hyperglycemia.
Okay, okay. Got it. Thank you.
But one question. So epinephrine at one hand inhibit glucose uptake, at the other hand it releases glucose. So
yes.
So it means at one hand it try to let it in a balance, or oh sorry, no sorry, my mistake. I understand it. Sorry. Thank you.
Okay, that's good. Okay, so any more doubt on this page?
No doubt. Thank you.
Okay. Now then comes the insulin. First, you need to know that how the insulin is synthesized in the body. Like we have discussed, any hormone which is being secreted from the body, it must be synthesized in the rough endoplasmic reticulum, right? Any hormone for the RER itself, any hormone for the Golgi, any hormone for the lysosomes, any hormone for the membrane of the cell, and any hormone which is being synthesized, which is being secreted from the cell, it will always be synthesized in the rough endoplasmic reticulum, right? And if you guys remember, whenever the hormone is synthesized in the rough endoplasmic reticulum, there must be a hydrophobic sequence. Remember?
Yes, yeah.
Okay, so first of all, what's going to happen when the RNA is formed from the nucleus? The RNA will enter the cytoplasm, right? And from the cytoplasm, this RNA, mRNA, will meet the ribosomes and the protein synthesis is started, right? And because this is a secretory hormone or a secretory protein, what's going to happen during the synthesis of this protein? Okay, N-terminal hydrophobic sequence will be added at the N-terminal, as the name suggests. A hydrophobic sequence will be added on the N-terminal of this insulin. Okay, now it is known as the pre-proinsulin. Okay, insulin or the protein with this N-terminal hydrophobic sequence, it is known as the pre-proinsulin, right? The function of the N-terminal hydrophobic sequence is, there are some proteins, okay, which recognize these sequences. Okay, so they will halt the translocation for some time. Okay, and what's going to happen? It will take the protein to the rough endoplasmic reticulum so that the synthesis of the protein can be happen to the rough endoplasmic reticulum only, right? When this protein meet the rough endoplasmic reticulum, this sequence is now cleaved off. Okay, and after the cleaving off of this signal, this protein is known as the proinsulin. Okay, so first is the pre-proinsulin, and now it's the proinsulin after the removal of this hydrophobic sequence. Can anyone remember the protein names which recognize these hydrophobic sequences?
Signal recognition proteins.
Exactly, SRPs, right? So now proinsulin is formed, and this proinsulin consists of this C peptide, alpha chain, and the beta chain. Okay, now this insulin will be secreted in the vesicles. Okay, after the modification with the Golgi bodies. Okay, this proinsulin will be secreted, will be stored in the vesicles. Now the vesicles will be secreted in the blood or in the plasma, right? And what's going to happen inside the vesicles? This C peptide will be cleaved off. Okay, inside the vesicles in which this insulin, the proinsulin, is stored. Okay, inside these vesicles, the C peptide will be cleaved off, and now this form, the insulin which contain only the alpha chain and the beta chain, this insulin is known as the activated insulin or the real insulin. Okay, so whenever you have an increased endogenous insulin secretion, whenever you have a increased endogenous insulin secretion, you always have a high C peptide level. Why? Because both this alpha beta chain insulin as well as a C peptide will be secreted simultaneously by the vesicles, by the exocytosis process. Is that okay?
Yes.
Okay, now whenever you have an insulinoma, like we have discussed, if you have an internal or the endogenous increase in the insulin levels, you will always have the high C peptide level. Okay, and whenever you take the exogenous glucose, because you always take it in the activated form, it only contains the alpha beta chains, not the C peptide. Okay, so whenever you take the exogenous insulin, it will always lack the C peptide. So patient will get the hyperinsulin symptoms, okay, but no C peptide level. That means it is a exogenous case. Okay, but whenever the patient is having an insulinoma or the patient is using a drug sulfonylurea, which causes the increased endogenous production of the insulin, okay, then in that case, patient can have a high C peptide level. So this C peptide level can help in differentiating the endogenous release of the insulin with the exogenous intake of the insulin. Okay, C peptide levels are very important. Okay, so step 1 will ask you that after the synthesis of this proinsulin, what's going to happen to the C peptide? So please remember, it would be stored in the vesicles, and along with the activated insulin, it will be secreted in the serum or the blood, right? So that the C peptide level will be raised along with the secretion of insulin. Okay. Yes.
Okay.
Okay. After synthesis, you need to know how the glucose, how the insulin will be secreted out of the cell. Okay. So first thing would be the high glucose levels. Can anyone remember what kind of enzyme in case of glucose, in case of a glycolysis pathway, what kind of enzyme is found in the liver?
Glucokinase.
Exactly, glucokinase. While in other cells, it would be hexokinase, right? And if you guys remember from the biochemistry lectures that this glucokinase had a very low affinity for the glucose, right? So only when the high glucose levels are available, this enzyme can be activated, right? So when the high glucose levels are available, the GLUT2 receptors are present on the liver, very important. GLUT2 receptors are present on the liver, and they also have a very low affinity for the glucose. So only when the high glucose levels are available, they will be intake by the cell. Okay, influx of the glucose will happen through these receptors. Okay, this glucose will undergo into the glycolysis pathway. Okay, finally to the Krebs cycle, TCA cycle, and ultimately what's going to happen? The ATP number will be increased in the liver. Okay, when the ATP to ADP ratio is increased, what's going to happen? This ATP will bind to the potassium channels and they will inhibit the potassium, right? And you guys already know that whenever the potassium channels are activated, they will throw out the potassium out of the cell, right? They will cause the efflux of the potassium from the cell, right? And as a result, when the ATP is binded to these potassium channels, the potassium channels will be inhibited. And as a result, the potassium will be started building inside the cell. And when the potassium is start building up inside the cell, what's going to happen to my membrane potential? It will increase, right? Depolarization will happen. And because of the depolarization, the calcium channels will be activated. Okay, and as a result, the calcium concentration will be increased inside the cell, which causes the exocytosis of the insulin vesicles or the granules. Okay, so first the glucose, which will undergo the glycolysis. Only when the ATP level is increased, the ATP will block the potassium channels. Potassium level will be increased inside the cell. Depolarization will happen, which will activate the calcium channels. Okay, calcium channel level will be increased inside the cell, which will causes the exocytosis of the insulin. That's how the insulin is released from the cell. Then you have one category of drug, which are the sulfonylureas. The function of these sulfonylureas is to inhibit these potassium channels. And by inhibiting the potassium channels, they activate the, they can cause the depolarization and then the similar step for the release of endogenous insulin. That's why I said whenever the patient takes the sulfonylureas, they're actually increasing the endogenous insulin synthesis. So they will have a high C-peptide level. Okay. So that's how the insulin is synthesized in your, released from the beta cells of the pancreas. Okay. Any doubt in it?
Can you again explain the mechanism of action of sulfonylureas?
See, sulfonylureas actually inhibit the potassium channels, right? Which is the ATP thing. See, this ATP is inhibiting the potassium channels, right? And same thing is the function of sulfonylureas. They inhibit the potassium channel so that the potassium will be started building up inside the cell, and as a result, depolarization will occur, which will cause the influx of the calcium. The calcium concentration will increase, which will cause the exocytosis of the insulin. So whenever you give the patient sulfonylureas, they're actually increasing the endogenous secretion of the insulin, and as a result, both the C-peptide levels as well as the insulin level will rise. Is that okay?
Yeah, got it. Thank you.
Okay, now, because you guys know that the enzyme glucokinase is only found in the liver, okay, and it is responsible for the glycolysis, okay, only in the liver, not in other cell, because in other cell it is the hexokinase. So there is a deficiency of this enzyme happens sometimes, okay, and the deficiency of this enzyme, which is the glucokinase, is known as the maturity onset diabetes of young, okay. Because of the deficiency of this enzyme, even though the glucose is present, it won't undergo the glycolysis, okay. Only when very high level of glucose is present, actually, not a deficiency, but you can say the affinity of the enzyme for the glucose is decreased. So as a result, high glucose levels will be required to activate the enzyme so that the glycolysis will happen, and the release of insulin can happen. So these patients who have this mutation in the enzyme, they have an increased baseline level of glucose, okay, and their glucose level will always remain same throughout the life, okay. Dietary changes, nothing gonna affect that. So no drug therapy is required for this patient. It just they have a high baseline glucose level, okay, which will always remains constant. But in case of pregnancy, because in case of pregnancy you have this resistance against the insulin. And can anyone tell me which hormone is responsible for the resistance against the insulin? Anyone? Which hormone causes the resistance?
HPL.
HPL. Yeah. In case of pregnancy, the patient will have a HPL in the body, and as a result, in the pregnancy, diabetes can occur, gestational diabetes. So it would be a patient who is having a history of gestational diabetes in multiple members of the family. Okay, the patient has a family history of gestational diabetes, and every member of the family, or most of the member of the family, they have a high baseline glucose level. Okay, and that's how you know that it is a case of maturity onset diabetes of young, or the MODY. Okay, and it is a deficiency of glucokinase. Okay, and that's why you're not having any kind of hemolysis. Okay, because in case if you have a hexokinase deficiency, then you are actually inhibiting the glycolysis in other cells of the body, and including the RBCs, right? And as a result, the glycolysis of the RBCs will be inhibited, and you will get the hemolysis in case of hexokinase deficiency. But in case of glucokinase deficiency, you are just having the baseline hyperglycemia. Okay, very important. Any doubt?
Sorry, can you repeat the why you don't have hemolysis?
Because you know that this glucokinase enzyme is only found in the liver, not in other cells. Other cells have the hexokinase. So if the deficiency or the mutation in the hexokinase occur, it can lead to the hemolysis, right? Because the glycolysis of the RBC will be inhibited, right? But in case of this enzyme deficiency, glucokinase, the deficiency will affect only the liver and the kidneys, and the beta cell of the pancreas, right? No other cell. So you will get a baseline hyperglycemia, no hemolysis.
Okay, because they're not going into the red blood cell in the first place. That's good.
RBCs are normal enzyme, right? It's just affecting the liver and the beta cells of the pancreas. Okay.
Yes, sir.
Okay. So we have discussed the synthesis of the insulin. We have discussed the release of the insulin. Now we need to discuss how the insulin act on the cell to cause their function. Okay. So you have the insulin receptors, which are the growth, which are the receptors for the growth factors. Okay, something like that. So insulin have the insulin receptors, and if you guys remember from the general pathology section, okay, these receptors are having the activity of the tyrosine kinase. Okay, why? Because these receptors, they have the tyrosine residues on them. Okay, and whenever the insulin bind to the receptor dimerization will occur. Okay, if I annotate it, you have this normal cell, any cell which is responsible for the insulin activity. Okay, and you have these insulin receptors. Okay, initially the receptors are like that. Okay, not dimerized. Okay, and all these receptors will have a tyrosine residues on them. Okay, and the enzyme which is known as the tyrosine kinase. Okay, when the insulin bind to these receptors, what gonna happen? The receptor dimerization will occur. The receptors will become dimerized, and these are the tyrosine residues on them. Okay, whenever the receptor dimerization occur, the enzyme which is a tyrosine kinase will become activate, and as the name suggests, it is kinasing the tyrosine. So it will add the phosphate group on the tyrosine, causing the tyrosine phosphorylation. Okay, enzyme tyrosine kinase. After the phosphorylation of these tyrosine residues, what gonna happen? Further, the RAS, if you guys remember the RAS, okay, which has a GTPase activity. Okay, the RAS will activate it. Okay, and it is undergoing the pathway which is known as the RAS and the MAP kinase pathway. Okay, which causes the cell growth. Right, it will activate other downstream proteins, ultimately activating the cyclins and the cyclin dependent kinases. The transcription factors will be activated. Okay, that will cause the cell growth and the DNA synthesis. That is a fun pathway. Second pathway is to undergo a, just give me a second. Second pathway is to undergo the phosphoinositide 3 kinase pathway, or the PI3K pathway. Okay, second pathway is the PI3K pathway. If this tyrosine phosphorylation undergoes this pathway, what's going to happen? It will activate the GLUT4 receptors. Okay, it will cause the mobilization of the vesicles which are containing the GLUT4 receptors on the cell surface. For say example, if it is a muscle cell, okay, and the muscle needs a glucose, what's going to happen? Insulin will bind to the muscle receptors, the tyrosine kinase receptors on the muscle, and as a result, what's going to happen? It will cause the movement or the mobilization of these vesicles which containing the GLUT4 on the cell membrane. Okay, and when these GLUT4 receptors bound to the cell membrane, what's going to happen? Glucose will be uptaken by the cells. And this is a mechanism how the insulin actually increases the density of GLUT4 receptors on the cell surface. And only GLUT4s are responsive to the insulin. Okay, not other receptors or the channels. Only GLUT4s are responsible for the insulin, responsive to the insulin. Okay, so remember two pathways: the RAS or the MAP kinase pathway and the PI3K pathway. RAS MAP kinase pathway, it will cause the DNA growth, cell growth. Okay, for the PI3K pathway, it can cause the increase receptors for the GLUT4. Okay, so that more glucose would be uptaken by the cell. Okay, and further after that, it can cause the synthesis of glycogen. Can anyone remember what enzyme is responsible for the glycogen synthesis?
Glycogen synthase and branching enzyme.
Okay, and these are activated by the insulin. And does anyone remember whether it is a dephosphorylation process or the phosphorylation process?
Dephosphorylation.
Yes, please remember dephosphorylation is for the glycogen synthesis and phosphorylation for the glycogen destruction, okay, or the glycogenolysis. And similarly, it can cause a lipid synthesis, the protein synthesis in the cell. Very important. Glycogen synthesis for the storage of the glucose, lipid synthesis, protein synthesis will be happen by this pathway, PI3K pathway only. Any doubt on the function or the action of the glucose of this insulin?
Is there any significance of that cell growth and DNA synthesis by insulin?
Yeah, of course, insulin causes the cell growth.
Okay. Okay.
I mean,
Uh,
all the yeah.
do we have to learn the whole MAP kinase pathway and the KRAS pathway in detail?
No, not complete pathway, but they can ask you about the mutations, right? Like in a general pathway, we've discussed this. I think we have discussed the whole pathway, and I told you, in what part you can get a deficiency or you or the super activation of these proteins so that they can cause the cancers like the KRAS and the BRAF. Remember the mutations in the KRAS and the BRAF, they can cause different cancers. So for that, you need to remember the different proteins which can cause different tumors. Okay, not the whole pathway. It is just for the understanding so that you can have a simplified view that what's happening inside the cell. Okay. But you do need to remember that this RAS MAP kinase pathways for the cell growth and that PI3K pathways for the increased glucose uptake and the synthesis of this lipid and proteins. Okay. The names are important, the pathway names. Okay.
Okay, thank you.
Okay. And
Dr.
other
Chole,
important, yeah, ask.
could you repeat the dephosphorylation and phosphorylation part again?
If you go back to the biochemistry, we have discussed that whenever the insulin whenever the insulin stimulates a cell, it will cause just give me a second. For the biochemistry, if you go back there, what's going to happen if the insulin bind to the receptors and it will undergo the this PI3K pathway? What's going to happen? It will activate a dephosphorylase enzyme. Okay, and by the action of this dephosphorylase enzyme, you can actually have the glycogen synthesis. Okay, and if the kinase enzyme is activated or the phosphorylase enzyme is activated, it can cause the lysis of the glycogen. Okay, and for the first aid, you can refer it on the page. Let me tell you. Yeah, go on the page 85 for the first aid 2020 edition. You will see how this the protein phosphatase enzyme is activated by the insulin, and by the action of this protein phosphatase enzyme, you are activating this glycogen synthetase, and the glycogen synthetase is responsible for the synthesis of glycogen. And similarly, this protein phosphatase enzyme is inactivating the glycogen phosphorylase kinase, okay, which is responsible for the lysis of the glycogen. Okay, so dephosphorylation for the glycogen synthesis and the phosphorylation for the glycogen lysis. Okay.
Got it. Thank you so much.
Okay. So that's about the pathway for the insulin. And one more thing that you must know. Just give me a second. Yeah. Apart from the tyrosine, you also have the serine on these receptors. Okay. Apart from tyrosine, you also have the serine on these receptors. And whenever the serine phosphorylation occur, it can inhibit the receptor, even though the insulin is binded. Okay. If the phosphorylation of the serine is occur on this receptor, the pathway will be inactivated. Okay. And this is the mechanism by which the TNF alpha inhibits the action of insulin. Okay. And similarly, the glucagon, which is which is the antagonist to the insulin, and the epinephrine, which is also antagonist to the insulin. Okay, that does the same thing. They causes the serine phosphorylation on the receptors, and as a result, the function of the these pathways will be inhibited. So very important to note. Okay, TNF alpha, glucagon, and the epinephrine, they causes the activation of serine kinase, and the serine kinase causes the phosphorylation of serine on these receptors. As a result, these pathways would be inactivated. Okay, so when the insulin binded, it will activate the tyrosine phosphorylation pathway. Okay, if the phosphorylation of the tyrosine won't occur, serine phosphorylation will occur, which can inhibit these pathways. Okay, very important. Any doubt?
No, no,
Please,
no.
Yeah.
quick question. This theory,
Yes, sir. Well, where sorry, the serine is going to be affecting the tyrosine that will dimerize, or on the insulin receptor?
See, insulin will work. Insulin will bind to the receptors. Okay, the receptor will be dimerized. But what's gonna happen if the TNF alpha is present? Okay, then instead of the tyrosine phosphorylation, it will be serine phosphorylation happen. Okay, TNF alpha inhibit the tyrosine phosphorylation and activate the serine phosphorylation. Okay.
Okay,
And
so
yeah.
okay, what you're saying is the insulin will come to the receptor, but
Okay,
because
yeah.
serine is attached, you will not have the dimerization. So
Yeah.
then the downstream effects won't. Okay, thank you.
Dimerization will occur. Dimerization will occur, but it won't activate the tyrosine kinase. Instead, it will activate the
Oh.
serine kinase. Okay.
Okay. Yeah.
And
And
similar
what
thing
are-
is for the and same thing is for the glucagon and epinephrine.
okay, the glucagon and the epinephrine are also giving serine.
Yeah. That's by
Okay.
inhibiting these pathways. Okay, very important.
All right.
Someone also asking some doubt.
Yeah.
Yeah, this serine phosphorylation, right? Does it occur alpha unit or the beta unit uh, of the receptor?
Sorry, I didn't understand. Please repeat it again.
So you know the insulin receptor, we have the alpha subunit and the beta subunit, right? So
Yes.
the serine phosphorylation, does it occur through the alpha subunit or the beta subunit of the
We don't know this much depth. I'm sorry to say, but I don't know about it.
It was actually beta subunit. I have a question in your it said beta subunit.
Okay, so it would be beta subunit.
Thank you.
Okay. Any more doubt? Anyone?
No.
Okay, so you now already know the function of the insulin. It will cause an increase in the glucose transport to the skeletal muscles and the adipose tissues. And please remember, only the skeletal muscles and the adipose tissue, they have the GLUT4 receptors. Okay, and the action of insulin is only on the GLUT4 receptors, not GLUT1, not GLUT2, not GLUT3, not GLUT5, only the GLUT2. Okay, very important. Second thing, after the glucose intake inside the cell, it can cause the glycogen synthesis. Okay, it can cause the lipid synthesis, like the formation of triglycerides. Okay, and another important thing, it can cause the sodium retention inside the kidneys, which is very important. Okay, it will activate the sodium potassium pumps. Okay, so that the cellular uptake of the potassium is also increased. Very important. So whenever you have a hyperinsulin levels, they will always cause the hypokalemia. Very important. High insulin levels can cause the hypokalemia. Okay, they will increase the amino acid uptake inside the cell. Okay, and after the amino acid uptake, they can cause the increased protein synthesis. Okay, and like I said, that they give the negative feedback to the glucagon release also. Okay, and they will also decrease the lipolysis in the adipose tissue. So their function is to form the protein, their function is to form the lipid, their function is to form the this glycogen. Okay, and two more functions, which is first one is to intake the this potassium inside the cells, and second thing is the sodium retention. And you can easily remember by the fact that this insulin actually activate the sodium potassium ATPase, so that more potassium could be influx inside the cell, and the value of sodium level in the blood will be raised. Very important. Okay, but unlike the glucose, insulin cannot cross the placenta. It is very important thing. Insulin has a large size, it cannot cross the placenta unlike the glucose. Okay, very important. And yeah, now we need to discuss the receptors, the type of these glucose transporters. Okay, first are the GLUT1. Okay, and these GLUT1s are found only on the RBCs and the brain mainly. Okay, and sometimes on the placenta also. Okay, so brain and RBCs are the major organs which are the which have the GLUT1. Okay, GLUT1 are not under the action of insulin. So whether the insulin is present or not, these GLUT1 will be activated in the RBCs in the brain, and they will continuously will be causing the uptake of glucose in the RBCs and the brain. Very important, the function of GLUT1. The GLUT2, which are present in the beta cells of the pancreas and the liver, kidneys, and the GI tract. Okay, these are the beta cells, liver, kidney, and the GI tract. Okay, whenever the glucose level are very high, only then these GLUT2 receptors can cause the intake of the glucose. Okay, because they have a kind of very low affinity for the glucose, right? And because of the low affinity, they will only intake the glucose only when the glucose level is high. While the GLUT1 receptors, they have a very high affinity for the glucose. So even though a slight bit of glucose is present in the blood, they can cause the uptake of it in the RBCs and in the brain. GLUT3, which are mostly present on the placenta, and some GLUT3 are also present on the brain. Okay, the GLUT4, which are present on the adipose tissue and the striated muscles, and these are the GLUT4 which are under the influence of the insulin. Okay, so only GLUT4 are under the influence of the insulin, not the GLUT1, 2, 3, or 5. GLUT5 is not for the glucose, but for the fructose. Very important. It is found in the GI tract. And remember, for the formation of the sperms, you need the fructose also, right, to give the energy to the sperms, right? So it is a GLUT5 which are present in the pathway. And which gland is responsible for the secretion of fructose?
Which?
Gland is responsible for the secretion of fructose.
LARKS, LARKS.
Oh, heavy name.
The lens and the kidney and I don't
No,
know.
not the kidney. I'm asking in case of spermatogenesis, which gland is responsible for the fructosynthesis?
Alfred?
Spermati.
Yeah. Take a guess.
Bulbourethral glands.
Not the bulbourethral glands.
Adix cells.
Spermati.
Which is the gland which has the highest role in this process of
Prostate.
the semen?
Prostate.
Not the prostate. Seminal vesicles.
Seminal.
Yeah.
Okay, 50 to 60% of the semen is consist of the secretions from the seminal vesicles, right? And one of them is the fructose. Other of them are the prostaglandins, okay, and some fibrinogen also to form the clot, right? So fructose, prostaglandins, and the fibrinogen, these are secreted by the seminal vesicles. So these GLUT5 receptors are actually found in the seminal vesicles to secrete the fructose in the semen, okay? Very important. And similarly, the same GLUT5 receptors are found also in the GI tract for the fructose absorption. Okay. Then the SGLT1 receptors and the SGLT2 receptors. SGLT1 receptors, they are found in the small intestine, and the SGLT2 receptors are found in the kidney, in the PCT of the kidney. Okay. They will cause the co-transport of the glucose as well as the sodium. And that's why the name sodium glucose transporters, SGLTs. They will cause the co-transportation of the glucose as well as the sodium. Okay, SGLT1 in the small intestine and SGLT2 in the kidney. Okay, so any doubt on the GLUT and the SGLTs?
I have sorry, I have so many questions today.
Yes.
Why does the seminal vesicle need fibrinogen?
To form the clot.
Oh, okay.
Fibrinogen function is to form the clot, and similarly in the semen they form the clot also.
Okay.
We will study that later in the reproductive section. Don't worry about that. We will go to the function of every gland and why these things are happening. We will tell you. Don't worry. Okay.
Okay.
Just wait. Okay. Yeah, I think that would be all. And as we have discussed already, the RBCs, they can only utilize the glucose, and that's why you need to maintain the glucose level in your body, right? Because every other tissue, every other organ in your body, they can use the ketone bodies in the fasting state. But RBCs, they can only feed on the glucose, right? That's why you always need to reserve the glucose for the RBCs. And the GLUT1 receptors, they have a very high affinity. Even a small amount of glucose is present, RBCs can take it very easily without the insulin. Okay. So I think it's very easy to remember the function of these GLUT receptors. Okay. Any more doubt on this page?
No.
And
No.
one more thing that you must remember, in case of exercise also, you have an increased receptor deficiency of the GLUT2 receptors. The GLUT4 receptors, not the GLUT2, I'm sorry. In case of exercise, whenever you do the exercise, you have an increased GLUT4 density, okay, on the cell surface because of the increased translocation. And it is not because of the insulin, but because of the calcium. Okay, whenever the muscles contract, they will release the calcium, right, for the contraction. And this calcium, it can also lead to the increased GLUT4 translocation to the surface, so that more glucose could be uptaken by the skeletal muscles. Very important. So in a patient with the diabetes, you always ask them to do the exercise, because if they do the exercise, then they can increase the receptor density of the GLUT4 receptors by the action of calcium. Okay, so that's why they can maintain a normal glucose level, right, without the need of insulin. Okay, very important. Yes, that would be all on this page. And in case of infection also, yeah, one important thing, in case of infection, okay, the cytokines like interleukin 1, 6, and TNF alpha, they increases the GLUT2 in the brain because you require your brain to, to ask the cells to do the functions, right? So the GLUT2 receptors will be increased in the brain and in the immune cells to respond to the stress or to respond to the infection, right? While the GLUT4 density will be decreased, okay, to reserve the glucose for the brain and the inflammatory cells. Very important. In case of any infection, in case of stress, the GLUT2 receptors will be increased and the GLUT4 will be decreased to conserve the glucose for the brain and the inflammatory cells. Important fact. So step 1 can ask you, in case of any infection, what's going to happen to my GLUT2 and what's going to happen to my GLUT4. So you must remember these two things. Okay, now any doubt?
No.
So the next page. And this is a maturity onset diabetes of young. We have discussed that in case you're having a deficiency of glucokinase or a decreased affinity of the glucokinase for this glucose, and as a result, high glucose level will be required to activate to release the insulin, right? So the patient will be having a baseline hyperglycemia, but they do not require any kind of drug, okay, because it will be present always. And this is the regulation. This is a regulation of glucose in case of fasting. Whenever in case of fatty state, the insulin will be released, okay, to conserve the glucose, okay, to store the glucose in their cell and to cause the hypoglycemia, okay. In case of fasting, okay, when you initiate the fasting, the first thing will happen will be the decreased release of insulin. Which is the first thing happen in case of fasting will be the decreased release of insulin, so that the peripheral glucose uptake would be decreased. After the insulin release is decreased, what's going to happen? The glucagon will be released. Second thing, okay. And this glucagon, like we have discussed, it mainly act on the liver to cause the hepatic gluconeogenesis, and secondarily, it will cause the glycogenolysis. First thing would be the glycogenolysis. After the glycogenolysis, when the glycogen is used, this glucagon will cause the gluconeogenesis. Okay. After if the blood glucose level will further drop, okay, if blood glucose level will further drop, it will activate the epinephrine. And as we have discussed, the major function of the epinephrine is to act on the peripheral tissues. Okay, what's going to happen? They will decrease the uptake of glucose by the cells. First thing. Second thing, they will increase the lipolysis. And third thing, they will act on the kidney to cause the gluconeogenesis. Okay, so they will mobilize the gluconeogenic substrates like the fats by causing the lipolysis. They will cause the gluconeogenesis in the kidney, and they will cause the decreased uptake of the glucose by the adipose tissue and skeletal muscles. And if further the glucose level dropping, then in that case only the cortisol and the growth hormone will be activated. And like we have discussed, the growth hormone will cause the decrease in the uptake of the glucose and as well as the gluconeogenesis to increase the glucose levels. And similarly, cortisol, it will increase the glucose level by causing the gluconeogenesis. Very important. Okay, so in last, the cortisol and growth hormone will be activated after some time. Okay, and because their function, it requires very much time for these enzymes to function, because they have to go into the transcription. Okay, then they form the proteins. Okay, then they form and then they can do the function, right? So it would take time for their action, so they will be in the last. Okay, so first thing will be a drop in the insulin. Second thing, activation of glucagon. Third thing is the activation of epinephrine, and finally the activation of cortisol and the growth hormone. That is a thing which is happen after the fasting. Okay, that would be now comes the adrenal gland. Okay, like we have discussed, we have 3 cells in the adrenal gland. One is the zona glomerulosa, second is the zona fasciculata, and third is the zona reticularis. For the glomerulosa, you will secrete the mineralocorticoids, which are the aldosterone. For the fasciculata, you will secrete the glucocorticoids, which are the cortisol. Okay. For the reticularis, you will secrete the androgens or the DHEA, right? Now we will discuss how these three cells or three tissues in the adrenal gland secreting all these hormones, right? So first you have the ACTH, and if you guys remember, the ACTH is responsible for the secretion of cortisol and the DHEA only, right? These mineralocorticoids, they are not under the action of ACTH, very important. Okay, please remember this fact. So you have the cholesterol, and if anyone remember in what organelles I secrete the cholesterol inside my cell?
Liver.
Smooth
Organelles in the cell.
plasmic reticulum.
Smooth endoplasmic reticulum.
Smooth endoplasmic reticulum is responsible for the synthesis of steroids, not for the cholesterol.
Peroxisome?
Exactly, peroxisomes. Okay, so in the peroxisomes, I'm synthesizing the cholesterol. Okay, then this cholesterol will go into the mitochondria, okay, to become the pregnenolone. In the mitochondria, this thing is happening. Okay, and in the mitochondria, you have the enzyme which is the cholesterol desmolase. Okay, now this pregnenolone is formed, which is and from the mitochondria, it will migrate to the smooth endoplasmic reticulum, and now all these reactions will be happening in the smooth endoplasmic reticulum. Is that okay?
Can you repeat the whole process, like starting from peroxisomes?
So you have the peroxisomes. Okay, in the peroxisomes, the synthesis of the cholesterol will happen. Okay, from the peroxisomes, this cholesterol will be migrated to the mitochondria. Right, in the mitochondria, you have the enzyme which is known as a cholesterol desmolase. In the mitochondria, this cholesterol will be converted into the pregnenolone. Okay, and from the mitochondria, this pregnenolone will be migrated to the smooth endoplasmic reticulum. Okay, and now all these reactions will be happening in the smooth endoplasmic reticulum only. Okay.
Okay, thank you.
Okay, now in the smooth endoplasmic reticulum, for the tissue, the zona glomerulosa, okay, they have the enzyme known as the 3-beta hydroxysteroid dehydrogenase. You do not need to remember the name of the enzyme at all. Okay, just know that in the zona glomerulosa, this pregnenolone will be converted into the progesterone. Okay, now this progesterone, now you need to remember the enzyme names. First one is the 21 hydroxylase. Okay, and this enzyme, by this step, the 21 hydroxylation, the progesterone will be converted into the 11 deoxycorticosterone, all the 11 doc, DOC. Okay, 11 deoxycorticosterone. Okay, this is a partially active state of the aldosterone. Okay, now by the action of the enzyme 11 beta hydroxylase, which causes the 11 beta hydroxylation, what's going to happen? This 11 deoxycorticosterone will be converted into the corticosterone. Okay, very important. And this corticosterone will be converted into the aldosterone by the action of enzyme aldosterone synthesis. Very important. So first one is the pregnenolone entered into the smooth endoplasmic reticulum in these cells, the zona glomerulosa. Okay, it will be converted into the progesterone. Now with the help of enzyme 21 hydroxylase, it will undergo the process 21 hydroxylation to become the 11 deoxycorticosterone or the 11 doc. Okay, 11 doc will undergo the process 11 beta hydroxylation by the enzyme 11 beta hydroxylase to form the corticosterone. Then by the enzyme aldosterone synthetase, it will be forming the aldosterone, which is a fully activating form. And you require the angiotensin 2 to activate this aldosterone synthetase enzyme. Okay, angiotensin 2 for the activation of aldosterone synthetase. Okay, now in case of zona fasciculata, what's going to happen? The ACTH will happen. Okay, ACTH will activate the cholesterol desmolase in case of zona fasciculata. Okay, to convert the cholesterol into the pregnenolone. Okay, this pregnenolone will be undergoing in a step by the enzyme 17 alpha hydroxylase. Very important, the name of the enzyme, which is 17 alpha hydroxylase. Okay, by the action of 17 alpha hydroxylase, it would be converted into the, as the name suggests, 17 hydroxy pregnenolone. So as the name of the enzyme, same the name of the product, 17 hydroxy pregnenolone. Okay, you also have the enzyme, the 3 beta, same. You don't need to remember the enzyme name. Okay, you have the progesterone in the cell also in the zona fasciculata. This progesterone will be converted into the same by the same enzyme into the 17-hydroxyprogesterone. Okay, now the 17-hydroxyprogesterone will be converted into the 11-deoxycortisol. Okay, so 11-deoxycorticosterone in the glomerulosa, and 11-deoxycortisol in case of fasciculata, and it is by the enzyme 21-hydroxylase. Okay, now after the action of the enzyme 11-beta-hydroxylase, this 11-deoxycortisol will be converted into the cortisol, which is the activated form. Okay, this cortisol will be converted into the cortisone. Okay, please note that it is not corticosterone. Corticosterone is for the aldosterone, and cortisone is the inactivated form of the cortisol. Very important. Okay, so this is about the zona fasciculata. In case of zona reticularis, the 17-hydroxypregnenolone will be converted into the DHEA. Okay, will be converted into the DHEA. Okay, now with the help of enzyme, again same, you don't need to remember. The DHEA will be converted into the endostrandione. Okay, it will be converted into the endostrandione. Okay, and by the and this endostrandione will be converted into the testosterone. Okay, now you have the enzyme which is known as the aromatase. Okay, and this aromatase will convert the testosterone into the estradiol, which is the activated estrogen. Okay, and the endostrandione, they will be converted into the estrone. Okay, estrone is the estrogen which is synthesized in the adrenal glands. Okay, and estradiol is the estrogen which is synthesized in the testis or in the ovary. Very important. Okay, for the ovary and for the testis, it would be the estradiol. Okay, and for the adrenal glands, it would be the estrone. Okay, and it is happened by the action of enzyme aromatase. And you have certain drugs like the anastazole, latrozole. Okay, all the drugs with the name zole in them, they will inhibit the aromatase enzyme, so that you can decrease the level of estrogen. Okay, then you have the enzyme which is a 5-alpha reductase, and this 5-alpha reductase can convert the testosterone into the dihydrotestosterone. Okay, and you have the drug which is a finasteride. Okay, and this drug it inhibits the 5-alpha reductase, useful for the treatment of BPH or the tumor of the prostate gland. Okay, because a prostate gland is under the direct action of the dihydrotestosterone. Okay, so any doubt on these pathways? Just
No,
remember
it's
just remember 3 enzyme names for the pathway. First, 17-alpha hydroxylase. Second, 21-hydroxylase, and third, 11-beta hydroxylase. Okay, only 3 enzymes that you must know. These enzymes you will again encounter them in the renal in the reproductive section. Okay, these 3 enzymes. So just 3 enzymes for now. Okay, so what the step 1 will do, they will cause a deficiency of one of these 3 enzymes, and they will ask you what's going to happen to the patient. So now we will discuss the deficiency of these 3 enzymes. First, we'll discuss the deficiency of 17-alpha hydroxylase. And as you can see, if the 17-alpha hydroxylase will become deficient, what's going to happen to my cortisol level? They will decrease. What's going to happen to my DHEA and the endostrandione level? They will be decreased. And as a result, because the cortisol levels are decreased, the ACTH level will be increased. Okay. And all the pregnenolone, which will be going to the fasciculata and the reticularis, it will be diverted to the glomerulosa to form the aldosterone. So what's going to happen? You will have a high level of aldosterone or the mineralocorticoids. And because the aldosterone level is very high, you will get a hyperaldosteronism, which means you're going to have a low potassium level. You have a high BP. Okay, you have a low cortisol, as we have suggested. And because of the low cortisol, you will have a high level of ACTH that can cause the hyperpigmentation, of course. Okay, you have the low sex hormones. Okay, and it mainly affects the male. Okay, because male requires the dihydrotestosterone and the testosterone for the development of the genitalia. So what's gonna happen? The male, they have the unambiguous genitalia, because that dihydrotestosterone is required for a development of the genitalia. If it is not there, then what's gonna happen? You will have the unambiguous genitalia and the undescended testis in case of male. What happened to the female? Female at the time of birth will be absolutely normal. Okay, but they have these 3-4 symptoms, which is high BP, low potassium. Okay, but at the birth, they will be absolutely normal. They require the sex hormone at the time of puberty, okay, for the secondary sexual development. So because they're lacking the sex hormones, so their secondary sexual development will not occur. Okay, they will get the amenorrhea. Okay, they do not have any cycles. They do not have any secondary sexual characters. So whenever you encounter a patient who is having an unambiguous genitalia and a male one, along with the high BP and low potassium, that means they're talking about the 17 alpha hydroxylase deficiency. Whereas other two conditions, they will be symptomatic in the female first, in the male later stages. Okay, first is a 21 hydroxylase deficiency. As you can see here, if the patient get a 21 hydroxylase deficiency, what's gonna happen? They cannot synthesize aldosterone, but yeah, they cannot synthesize the aldosterone as well as the deoxycorticosterone. Okay, and now what's gonna happen? All of the pregnenolone will be forming the 17 hydroxyprogesterone or the 17 hydroxypregnenolone. Okay, but still you need the 21 hydroxylase for the cortisol synthesis. So again, you will have the deficiency of cortisol, and all of these hormones will go and form the testosterone and the androstenediones, right? So what's gonna happen? You have a very low mineralocorticoid levels, low aldosterone, and because of that, you will have a high potassium level, a very low BP, okay, low cortisol again, high ACTH that can cause the hyperpigmentation, of course. You will have a high level of sex hormones. That means male will be absolutely normal, okay, no symptoms in the male other than the low BP and this high phosphate. But in case of females, the virilization will occur. In case of females, virilization will occur because of high level of the sex hormones, right? Male will be absolutely normal at the time of birth, but they will get the precocious puberty, which is the early puberty in male. Okay, before the age of 7 or 8, they will get the puberty in case of male, and in case of female, they will get the virilization. Very important. And of course, the salt retention will occur. Okay, very important.
All these things.
Then comes the 11 beta hydroxylase deficiency. And as you can see, in case of 11 beta hydroxylase, you cannot convert the deoxycorticosterone into the aldosterone, right? So ultimately, what's going to happen? You have a high level of deoxycorticosterone. And because you require the 11 beta hydroxylase for the synthesis of cholesterol, for the synthesis of cortisol, so cortisol won't be there. Low level of cortisol, high level of DOC, 11 DOC, low level of aldosterone. What's going to happen? You will have a high level of sex hormones because all of the pregnenolone and all of the progesterone will form the testosterone and the androstenediones, right? So if you look, you will have a high level of deoxycorticosterone. And like I told you, this deoxycorticosterone has a weak aldosterone activity. It is a weak mineralocorticoid. So what's going to happen? Because of the high level of this hormone, you will have a potassium loss, you will have the high BP, you will have the low cortisol, you will have the high sex hormone level. And of course, this will be very symptomatic in the females first. The females will get the virilization. Male, again, even they have a high sex hormone level, it won't be they won't be symptomatic at the time of birth, but they will have a precocious puberty. Okay, and yeah, what about the renin activity? In case of 11-deoxycorticosterone, because they have a weak mineralocorticoid activity, it will suppress the renin. Okay, so RAS system will be inactivated. Very important. Okay, in this case, in case of 21 hydroxylase, because aldosterone were not there, so renin will be inhibited. Renin will be activated. A high activity of renin will be seen. Okay, in case of 17 alpha hydroxylase, you have a high mineralocorticoid activity, so renin will also be inhibited in the 17 alpha hydroxylase deficiency. Okay, any doubt on this page?
Yeah, I have a question. So in like explaining the precocious puberty, right? It only happens in males, but why didn't they write XY in both of those?
XY in?
Like how in 17 alpha hydroxylase they wrote XY ambiguous genitalia and XX, lacks secondary sexual development. In 21 hydroxylase and in 11 beta hydroxylase for precocious puberty, they did not write male. They did not write XY. They didn't specify like.
I don't know about it, why they didn't mention it. It's just a first aid thing, but yeah, you have the precocious puberty in males. That is confirmed, okay? So don't worry about that.
Okay, so it's only in males, right? It's not in females, right?
Yeah, because you have the sex hormone level very high, right? And male need the sex hormone for the to reach the puberty, right? And if they have a high level of this sex hormone, they will reach the puberty at very early stage. So they will get the precocious puberty. But females, because of the high sex hormone level, they will get a virilization. Okay.
Okay. And the decrease in renin activity in 11 beta hydroxylase is due to the 11 deoxycorticosterone?
Yes, because it is a weak mineralocorticoid, so it can cause a high BP and low potassium. And if you remember that this RAS system is required to cause the high BP and low potassium, right? So RAS will be inhibited.
So 11 deoxycorticosterone can act like aldosterone, right? In RAS.
Yeah, yeah, a weak aldosterone.
Okay, thank you.
And please note that all of these disorders are autosomal recessive. Okay. And because in all of the disorders, you are having a low cortisol level, you have a high ACTH level. And like we have discussed, these ACTH, endorphins, and the MSH, they have a common origin. Okay. And whenever you have a high ACTH levels, it will also activate the MSH. So you will get the hyperpigmentation in all of these three disorders. And apart from that, because of a high ACTH level, okay, it causes the proliferation of the fasciculata and the reticularis. So what you will get is the bilateral adrenal gland enlargement. Very important. You will get the bilateral adrenal gland enlargement. And all of the symptoms that you are getting is because of this low cortisol, right? Because you're having the low cortisol, you're having a high activity of ACTH, and this high ACTH will be forming more pregnenolone, more progesterone, so that more of them could be converted into the aldosterones and into the sex hormones. So if you inhibit the cortisol at the, if you give the patient cortisol, or if you inhibit the ACTH in the first place, not the cortisol, if you inhibit the ACTH in the first place, then what's going to happen? The progesterone won't be there, right? So no progesterone means no aldosterone. No progesterone means no testosterone. So you can have a relief of the symptoms. Okay. So the major therapy that you give to the patient in case of the deficiency of these enzymes is the inhibition of the ACTH, because ultimately this thing is responsible for all the symptoms. You're having the increased release of all these hormones because of increased ACTH levels, right? So what thing you will do? You will give the patient cortical supplement, the supplements of the cortisol, along with the inhibition of the ACTH. This is a treatment goal. Okay, very important. So treatments will be the ACTH inhibitors. Okay. Any doubt on that?
No.
And remember one more drug, which is the meteropone. Okay, you have the meteropone stimulation test. What happens is meteropone inhibit the enzyme 11 beta hydroxylase, and as a result, this deoxycortisol, which is the inactivated form, cannot be converted into the cortisol. And as a result, the cortisol level will be decreased. So the decreased cortisol level will stimulate the ACTH. It will cause the increased release of ACTH, so that more deoxycortisol will be released, but it cannot be converted into the cortisol again because of this presence of the drug. So what's going to happen is 11 deoxycortisol, okay, will be detected in the urine. Okay, it will come into the urine, and we will detect the levels of this deoxycortisol. So if you give the patient meteropone and they're having an increased level of this deoxycortisol in the urine, that means you have an intact hypothalamic pituitary adrenal gland pathway, right? So this meteropone stimulation test is used to detect the damage in the hypothalamo pituitary adrenal gland pathway. Okay, so if you have an intact pathway, then you have an increased level of this deoxycortisol, which can be detected in the urine. So you can say that this pathway is intact. Okay. Any doubt on that?
No, sir.
No.
Okay. And apart from that, one more thing, that you have the placenta. Okay. And because all of these hormones are increasing in the females, in the baby, in the fetus, right? Because they're all of these hormones will be increasing in the fetal life, right? But these hormones, and because the fetus is in the female, even though the testosterone level is increasing in the fetus, okay, it won't affect the mother. It won't cause any symptom in the mother. Can anyone tell me why?
Because of placenta,
And why?
it
Because of placenta?
aromatizes the excess and
Yeah.
pushes into Yes.
Exactly, because they will aromatizes the excess testosterone or the androgens, so that they cannot be converted. So that they cannot be entered into the maternal circulation. So now, what happened if the patient become if the fetus become deficient of the aromatase? Then, because placental aromatase is become deficient, now all of the testosterone which is in the fetus, it can also be entered into the
Mother.
in the mother, right? So along with the fetus will get the virilization, and along with that, the mother will also get the virilization. Very important. Okay, so mother will also shows the signs of high testosterone, like the hair growth. Okay, like the muscle development. Okay, like the virilization. Okay, so please remember, whenever you get a deficiency of the aromatase or the placental aromatase, I must say, the pregnant female will also develop the signs and symptoms of the high testosterone. Okay, the female will also get the virilization. But in case if you have the other coenzyme deficiency, then only fetus will be affected, mother will be normal. And soon after the delivery, all of the symptoms of the female will be gone, because now the no testosterone will be available to cause the symptoms, right? So if the step one, if the step one ask you if the step one give you a certain scenario in the question stem, where the pregnant female is also having the symptoms of high testosterone, virilization, okay, so that means it is a deficiency of aromatase. Okay, and in the baby you will see the salt wasting or high BP or something like that. Okay, if only baby is affected, female is not affected, then only you will suspect the deficiency of these three enzymes. Is that okay?
Yes, yeah.
Sorry, what?
Someone is asking why.
Yes, sir. If a pregnant mother is taking ketoconazole or any of the other aromatase inhibitors, will the baby have the virilization effects as well?
Please ask it again.
Okay. If a pregnant woman were on the aromatase inhibitors, would
A second, let me just turn off the background noise. Yeah, now ask.
yes, sir. So if a pregnant mother is given an aromatase inhibitor, will that affect the
Yes.
baby as well? Like, will that show virilization in the baby as well?
Yeah, I think yes, because in case of aromatase inhibition, what's gonna happen? The level of testosterone will be increased, right?
Mm-hmm.
So that can affect, of course.
Okay, so I just wanted to make sure it could cross the barrier. Thank
Yes.
you.
Yes. But because in case of these scenarios, in case of congenital adrenal hyperplasia, you are actually having the high ACTH, which means high production of the testosterone. So not the inhibition of the aromatase, but high production of the testosterone is responsible, right? So this is a very important thing. Okay.
Mm-hmm. So you're saying that these deficiencies are not necessarily that because it's being turned off, it's more that there is overproduction.
Yeah, exactly. Like I told you, the treatment is to inhibit the ACTH. The main treatment is to inhibit the ACTH, right? Because the ACTH is responsible for all of the increased synthesis of of all these hormones, right? Because ultimately, if you're not having any cortisol, that it will give the negative feedback to the ACTH. It will ask the ACTH to do something. So ACTH will be increased, and it will increase all of these hormones, but nothing gonna happen because enzyme is deficient. So instead, it will cause the increased testosterone. It will cause the increased aldosterone, right? So all of the symptoms are because of increased ACTH. So the main treatment is to inhibit the ACTH and to give the patient cortisol supplements.
Okay. Okay. Thank you.
Thank you. Okay. So any more doubt on this page?
No, thank you.
Okay. Now comes the cortisol. And now you need to know that there's ACTH, MSH, and the endorphins. Okay, they have a common origin, which is from the POMC. Okay, also known as melanocortin. Okay, the POMC or the pro-opio melanocortin. Okay, pro-opio, which means the opioids, which are the beta endorphins in your body. The natural opioid in your body is the beta endorphin. Melano for the melanin synthesis, and the cotin for the ACTH. So pro-opio, melanocortin. Okay, the ACTH, MSH, and the endorphins, they have a common origin. Okay, and whenever the cortisol releasing hormone is released from the hypothalamus, what what's going to happen? It will stimulate the POMC. Okay, the POMC will form more ACTH, more MSH, more endorphins in the pituitary. Okay, and the ACTH will be go to form the cortisol, right? So whenever you have a high ACTH level, okay, along with the ACTH, you always have a high melanocyte stimulating hormone level as well as the endorphins level. So whenever you have a high ACTH, you will always have the hyperpigmentation. Is that okay?
Yeah.
And now we discuss how this cortisol is synthesized in the body. So first thing is the hypothalamus. Hypothalamus will release the hormone, which is the corticosteroid releasing hormone, or the CRH. It will act on the anterior pituitary to release the ACTH. We have discussed the POMC will be converted into the ACTH, MSH, and endorphin. So along with the release of ACTH, the MSH and endorphins will also be released. ACTH will enter the blood circulation. It will go to the adrenals. On the adrenal cortex, which is a zona fasciculata, it will release the cortisol there. Okay, and finally, when the cortisol will be in the blood, it will cause its function. Okay, cortisol also gives the negative feedback to the anterior pituitary as well as the hypothalamus, and the release of cortisol is happen mostly in the stress, okay, and in the circadian rhythm. Very important. The highest release of cortisol will be happen in the morning, just after you wake up. Okay, it is also very important thing, and this is because of circadian rhythm. So stress and circadian rhythm, which is early in the morning, you will have the high release of cortisol. Okay, so that's why this cortisol is also known as the stress hormone. Okay, and let's discuss about the function. Function first, it will increase the appetite. Okay, second, it will cause the high blood pressure. If you guys remember, I told you that this cortisol will causes the upregulation of the receptors for the sympathetic nervous system, which are the alpha receptors, and that's why I told you in case of Addison's disease, where you're having the in the crisis time. Okay, uh, even if you give the patient epinephrine or the norepinephrine, it won't increase the BP of the patient. Okay, you need to give the patient cortisol, because cortisol is responsible for the upregulation of the alpha 1 receptors. Even though you give the patient epinephrine, there won't be any alpha receptors for them to activate, right? So in case of adrenal crisis, you always give the patient cortisol first, then the epinephrine or the norepinephrine. Okay, so it would be a permissive action. Okay, and does anyone remember what this permissive action means?
It allows action of norepinephrine and epinephrine on the receptors.
When
Yeah.
one drug increase the potency of another drug.
Not the potency.
You need
Efficacy.
you need the presence of it to be fully effective.
Yeah, you need the presence of that enzyme or that drug in order to cause 100% effect of the other drug. Okay, this is the synergistic. This is the permissive action. Okay, and at high concentrations, please remember, at high concentration, this cortisol also has the mineralocorticoid activity. So whenever you have a Cushing syndrome or hypercortisolism, you will always have the activity of aldosterone also. So you will get the high blood pressure, you will get the hypokalemia. That's why in the Cushing syndrome. Okay. Third thing, it will increase the insulin resistance, can cause the diabetes. So it will increase the high glucose level, right? It would be a diabetic hormone. Okay, it will cause the this gluconeogenesis. It will cause a lipolysis. It will cause the proteolysis. Okay, it will decrease the glucose utilization, ultimately increasing the glucose level. So just think about one thing, which is the increase in the glucose levels. Okay. Other thing, it will also decrease the fibroblast activity. That means it can cause a poor wound healing. That's why in case of Cushing syndrome, you have the poor wound healing or the delayed wound healing because of inhibition of the fibroblasts. Okay, and because they're inhibiting the fibroblast activity, they will also decrease the collagen synthesis, And that's why, because the collagen synthesis is decreased, you will get the striae in the skin. Okay, because the epidermis, it contains the collagen, right? Now the collagen is lost, so you will get the striae. Okay, it also decreases the inflammation. You guys already know that. It can cause the apoptosis of the lymphocytes. Okay, first thing. And it will cause the WBC adhesion inhibition. It will inhibit the WBC adhesions, and as a result, the neutrophilia will occur. But these neutrophils are kind of dysfunctional because they cannot cross the vascular wall, right? Because they need to be adhered to the vascular wall in order to cross the vessels, right? So you will get the neutrophilia, but it is kind of an artificial neutrophilia, right? Because all of the neutrophils which were first adhered to the these vessel walls, they will be enter into the blood circulation, right? So we get the artificial neutrophilia. Okay, it will cause the apoptosis of the lymphocyte, so you will get the lymphopenia. Okay, it will also cause the eosinopenia. Okay, they will kind of trap the eosinophils in the lymph nodes only. So all of the eosinophils will be trapped in the lymph nodes. They cannot enter into the blood circulation, so we get the eosinopenia also. Okay, they will also block the histamine release from the mast cells. Okay, they also inhibit the prostaglandins and the leukotrienes pathway. Okay, they inhibit the production of leukotrienes and the prostaglandins. And they also blocks the interleukin-2 production by inhibiting the NF-kappa B, if anyone remember, right? They inhibit the NF-kappa B, inhibiting the interleukin-2 production. Okay, they also decreases the bone formation by inhibiting the osteoblast activity. Very important. They inhibit the osteoblast activity and they activate the osteoclast. Very important, right? So they will cause the decreased bone formation. Okay, so these are the functions of the cortisol. So step 1 can ask you a certain scenario in which the patient is having a stress. Okay, and they will ask you in stress what hormone could be what enzyme could be increased. Okay, so they will give you certain list, and I remember the question, and one of them would be the enzymes for the gluconeogenesis, and it is because of the cortisol. So please remember, cortisol will be acting on the glucose. It will activate the enzymes in the glucose to cause the gluconeogenesis. It was the question in the UWorld, or I don't know, in the NBME maybe. Okay, where they asked me about stress, and they asked which enzymes would be activated. Okay, so it would be the enzymes for the gluconeogenesis in the liver. Okay, yeah, they asked the location of the enzymes which would be activated in the stress. So it would be the liver. Okay, regulation we have discussed about the HPA axis, about the stress we have discussed that. Okay, how the ACTH release will also cause the release of CR, this MSH and the endorphins, we have discussed that. Okay, so stress can cause the hyperglycemia. Okay, note that thing also. Yes, so any doubt on the cortisol?
No.
No, it's
So I
good.
think we should take a 5 or 10 minutes break, and then we will meet again. Okay.
Okay.
Yeah, along with decreasing this activity of the fibroblast cells, the cortisol this also inhibiting the inflammatory response, right? And because you guys know that for the proper wound healing, you require the inflammatory phase, right? So if the inflammatory phase is not there, then it also promotes the poor wound healing. Okay, so 2 things for the poor wound healing. First is the fibroblast activity, and second is the loss of inflammation, right? So remember these 2 points. Then the hormones which regulates your appetite. Okay, first is the ghrelin, which is secreted by the stomach. Okay, and it acts on the lateral area of the hypothalamus. Okay, and it causes the hunger. Very important. Ghrelin, it causes the hunger by acting on the lateral area of the hypothalamus. So if the lateral area of the hypothalamus become damaged, what's gonna happen? Your hunger will be inhibited, and what you will get is the loss of weight. Okay, so damage to the lateral area can make you lean. You can easily remember that damage to the lateral area of the hypothalamus. Okay, you can get lean. So ghrelin, which is released by the stomach. Okay, it acts on the lateral area of the hypothalamus to increase the appetite. Okay, and whenever you take the meal, okay, the secretion of this ghrelin will always decrease. So if I draw the graph, let's take this is the meal time. Okay, this is the fasting time, then again the meal time, then again the fasting time, and then again the meal time. What's going to happen to the level of my ghrelin? In the fasting time, which is this period, the levels will be increased. Okay, just before the meal time, the level will be at the peak. When I take the meal, the level will again decrease. Okay, when the fasting again start at the midpoint, the level will be again start rising. Okay, again rising, and just before the meal time, it will be at the peak. When I take the meal again, the level will again start decreasing. Okay, again at the fasting time, the level will start rising. They will reach at the peak. Just after the meal, the levels will again decrease. Okay, please remember this graph, very important. These are the level of this ghrelin at the time of meal and at the time of fasting. Step 1 will ask you, they will give you a certain graph of a certain hormone, and they will ask you what hormone it could be. Okay, so remember for the ghrelin, just before the meal, it would be at the maximum, at the peak. Just after the meal, it will be start decreasing. Okay, very important. And you also need to remember the location of the action of this ghrelin, which is the lateral nucleus. Okay, so lateral nucleus of the hypothalamus, whenever it get damaged, ghrelin cannot act on it, and you will get the lean. So lateral nucleus damage can make you lean. The easy way to remember this. Okay. Then comes the leptin. Okay, and leptin is released from the adipose tissue. Very important. Leptin is released from the adipose tissue. It acts on the ventromedial nucleus of the hypothalamus. Very important. It acts on the ventromedial nucleus of the hypothalamus. Okay, so whenever you get the damage of the ventromedial nucleus, okay, the damage to the medial nucleus can make you massive. The easy way to remember. Damage to the ventromedial area can make you massive. M for medial, M for massive. Okay, because the leptin cannot act on it because it is a hormone which causes the satiety. It will decrease your appetite. It will cause the satiety by acting on the ventromedial area of the hypothalamus. Okay, so whenever you have the obesity, because in the obesity you have too much of the adipose tissue, what's going to happen to your leptin levels? They will be very high, right? And whenever you do the fasting, the adipose tissue level will be decreasing in your body, and as a result, the leptin level will be decreasing and the ghrelin level will be rising. Okay, and this is a mechanism. This is a reason why you cannot continue fasting for a long time. Okay, those who are trying to reduce weight, they ultimately end up more eating, right? Because of this ghrelin. Okay, and if you guys remember one syndrome which is known as a parietal villi syndrome, remember from the biochemistry lecture? Yes.
Beckwith-Whiteman syndrome.
Yeah.
Beckwith-Whiteman syndrome, hyperphagia.
Not the Beckwith-Whiteman, but the parietal villi syndrome. Yeah, the Beckwith-Whiteman also, but again, in case of biochemistry, I was discussing, because we have not discussed that syndrome yet, the Beckwith-Whiteman, but we have discussed the parietal villi, right?
Oh, Prader-Willi, like the imprinting disorder?
Yeah, the 15th chromosome disorder, remember?
Yeah, with Angelman, that's the opposite of it.
Yeah, in that case, you will get the obesity and the hyperphagia, right?
Yeah.
And that is because of this ghrelin only. You will get the mutations, you will have the high level of ghrelin, and the patient will become the hyperphagic. So you will have the obesity. Okay, so this is the parietal villi syndrome. Okay, and second thing is the sleep deprivation. Whenever you cannot sleep properly, you will have the increased hunger always. Why? Because of this ghrelin. Okay, and obese individuals, they have the high level of leptins. Okay, and this leptin actually reduces the neuropeptide Y. Another important fact, neuropeptide Y is another neuropeptide which is responsible for the eating, for the hunger. So leptin will also decrease the neuropeptide Y. Okay, in case of PCOS, the polycystic ovarian syndrome, in case of PCOS, you have the dysregulation of the leptin. Okay, and this is the reason you will get the PCOS. Very important. Okay, high level of adipose tissue will cause the high level of leptin in case of obese females, right? And they will get the PCOS. Okay, it is a reason, one of the reason, not the only reason, but one of the reason of the PCOS. Okay, and in case of sleep deprivation and in the starvation, you will get the reduced level of leptin. Okay, so you will get the increased hunger. So leptin make you thin, and in case of a ventromedullary area damage, you will get the massiveness. Okay, any doubt on that? In leptin and ghrelin?
No. No, it's good.
Okay, and then finally comes the cannabinoids or the endocannabinoids. These are the endogenous opioids in your body. Okay, the mu receptor, the kappa receptors, they're actually made for these endocannabinoids. Okay, and they will also increase the appetite. Very important. They secreted along with the ACTH and along with the MSH. Okay, and yeah, that's all about the endocannabinoids. Okay. Yeah, I think that would be it. Any doubts so far on this page?
No.
So
just one quick question.
Yeah,
Doctor.
please ask.
So PCOS is due to a decrease in leptin, you're saying?
PCOS is
one of the reasons of PCOS is due to a decrease in leptin.
Due to increase in the leptin, a dysregulation in the leptin, you can say, right? Dysregulation in the leptin that can lead to the PCOS.
Okay, so dysregulation, what do you mean decrease in leptin?
Increase mostly.
Because leptin makes you thin, right? So if you have
yes,
if you have an increase,
leptin will see, leptin actually makes you thin, but in obesity you are having high levels of leptin, as you can see, right? Whenever you have the obesity, you will have a high levels of leptin, right? And this is one of the cause of this PCOS. It can interfere with the with your steroids, with the estrogen pathway, and with the with the insulin thing, and that's a reason, one of the reason why we will get the PCOS.
Okay.
You will see that later again in
So
yeah.
So you have the increased leptin, but you're not getting the thinning effect of it?
See, like I told you, if you can see this line, in case of obesity, you have the leptin production increase because the leptin is secreting from the adipose tissue. Leptin makes you lean, no doubt, but in case of obesity, you have the high leptin level. Okay.
So you're saying that there's just decreased sensitivity, right? Or that it's there, like the anorexigenic effect or like the satisfaction.
See, it is kind of a compensatory mechanism, a kind of negative feedback thing. Okay, whenever you get too much obese, it is kind of a negative feedback thing that the leptin levels will start rising. Okay. But you're eating too
I'm
much.
not understanding it.
See, where the leptin production is occurring in your body? Tell me.
Adipose tissue.
So if you have too much of the adipose tissue, what's going to happen to the leptin?
It's going to increase.
So if you are obese, you have too much of the adipose tissue, then what's going to happen to the leptin again?
Oh, it's going to go up. I see where you're going with this. Okay.
Right?
Yep, I get it.
Okay, yeah. So, and similarly, because of the obesity, okay, you have the adipose tissue, and remember that location of the aromatase is in the adipose tissue, right? One of the location of the aromatase is in the adipose tissue. So because of this high adipose tissue level, you will also get the high estrogen level. Okay, so because of these hormone dysregulations, the high level of estrogen, high level of this leptin, okay, high level of insulin, because of all of them things, okay, you will get the
like
PCOS
aromatization.
Yeah, aromatization.
Okay.
Okay. So it is one of the cause of the PCOS, not the only cause, but one of the reason you get the PCOS. Okay.
Yeah.
And neuropeptide Y, it is also responsible for the hunger. Okay. So inhibition of the neuropeptide Y can actually reduce your appetite, which is a function of this leptin. Okay, now the very important page, which is you need to exactly remember which hormone undergoes which pathway. Step 1 will ask you this. Okay. and I have written it here that TNF alpha causes the insulin resistance by activating the serine kinases, which causes the phosphorylation of the serine residues on the insulin receptors to cause the inhibition. Okay, similarly, the glucagon and the epinephrine, they does the same thing. Okay, so now comes the signaling pathways, and first one is the CAMP. You need to remember this mnemonic, which is the flat champ chug. Okay, F for the FSH, L for the LH, A for the ACTH, T for the TSH, C for the CRH, small h for the HCG, alpha and beta, A for the ADH, the champ A. Okay, M for the MSH, P is for the the parathyroid hormone. If you guys remember, we checked the cyclic AMP level in the urine for the activity of this PTH, right? So P for the PTH, okay. C for the calcitonin, H for the histamine, and histamine H2 receptors. More specifically, histamine H2 receptors, because histamine H1 receptors are undergoing IP3 DAG pathway, okay, and H2 are for the cyclic AMP pathway. And can anyone tell me where does the H2 receptors located and where does the H1 receptors located?
Gastric parietal cells, H2 receptors,
Okay.
and H1 are the histamine receptors in the blood vessels and
in the vessels.
No, in the actually the basophil cells and
Basophil cells are actually
basophil
releasing
cell-
the basophil cells actually releasing the histamine, right?
yeah.
They are the one responsible for the release of histamine. So where does the H1 receptor is found?
Neurons.
Yeah, neurons.
Okay, or any other simple area? What are the actions of histamine? Anyone? 2-3 actions, please remind me. They will cause a skin allergy. Okay, they will cause the itching first. Second?
Itching.
Redness, vasodilation.
Okay, vasodilation, third part. And then what does the histamine do in lungs?
Bronchoconstriction.
Exactly, and it is by the IP3-DHE. Remember, IP3-DHE pathway always causes the calcium influx. You don't actually need to remember the locations very well. If you just need, if you just think about the actions of the hormone, whether they're causing the constriction or the dilation, you can easily remember the IP3-DHE or the or the cyclic AMP. Because cyclic AMP always causes the vasodilation and IP3 always causes the vasoconstriction or the smooth muscle constriction, to be more specific, right?
Yeah.
So in the lungs, you will have the H1 receptors. In the vessels, you have the H2 receptors. In the GIT, again, you have the H2 receptors. Okay.
In the vessels, you are saying H2 receptor, right?
Yeah, because the vasodilation occurs, right, in the vessels. Okay, then histamines, and for the G, again, you have the glucagon, and for the G, you have the GHRH, which is a growth hormone, regulatory hormone. Okay, the easy way to remember is to write them down again and again, along with the mnemonic. Okay, because there are many hormones start with the G letter, many hormones start with the A letter, many hormones with the C letter. Okay, so you need to just write them down again and again. After 2-3 weeks of continuous writing, you will be able to remember them. There is no easy way other than this. Okay, then for the cyclic GMP, you guys already know about the ANP, BNP, and the nitric oxide. Very easy. Okay, no need to remember them. Okay, cyclic GMP. Then for the IP3-DAG pathway, every hormone which can cause a vasoconstriction or the bronchoconstriction, they are undergoing the IP3-DAG. Some other ones include the GnRH. See, the GnRH is basically IP3-DAG. Okay, and after the IP3-DAG, it will be released from the hypothalamus, acting on the pituitary by the IP3-DAG pathway, and in the pituitary, it will be releasing the FSH and LH. Okay, then FSH and LH will be going to your ovaries and the testosterone and acting through the cyclic AMP pathway. Okay, so you can easily remember, first pathway is the IP3-DAG in the synthesis of your steroids, and second pathway is the cyclic AMP, which is for the LH and FSH. Oxytocin, which causes a smooth muscle contraction in the uterus. Remember the labor, it causing the contractions. That means the IP3-DAG pathway for the oxytocin. ADS, the V1 receptors, which are responsible for the vasoconstriction. Okay, V2 receptors are for the aquaporins. So V1 are for the IP3-DAG pathway. The TRH, okay, for the thyroid synthesis. First hormone is the TRH, which act on the pituitary by the IP3-DAG pathway, just like your GnRH. Okay, acting on the pituitary, it will be releasing the TSH, which act through the cyclic AMP, just like the FSH and LH on the thyroids. Okay, so the the hypothalamus hormones, GnRH and the TRH are for the IP3-DAG, and the pituitary hormones are for the cyclic AMP. Again, histamine, which causes the bronchoconstriction. H1 receptors, histamine is for the IP3-DAG. Angiotensin 2, it also causes the vasoconstriction. If you guys remember, the efferent arterioles constriction by the angiotensin 2, it is also by the IP3-DAG pathway. The gastrin, it works through the IP3-DAG pathway again. Okay, and how does this pathway work? It is by first is the activation of this phospholipase C. The phospholipase C, as the name suggests, it will degrade the lipids in the cell membrane, okay, to release the IP3 and the DAG. Okay, the IP3 will release the calcium, and the diacylglycerol, it will activate the protein kinase C along with the calcium later on, right? Protein kinase C will be activated. It will cause the bronchoconstriction or the vasoconstriction or any other smooth muscle constriction. Okay. So just think about all the hormones which can cause a constriction. They will be acting through the IP3-DAG pathway. Okay, the easy thing to remember. Then all the growth, all the steroid hormones. Okay, all the steroid hormones that you guys know, including the vitamin A, D, E, K, which are the fat soluble vitamins. Okay, they always act through the intracellular receptors. Okay, first of all, they will enter inside the cells, and the receptors are found in the cytoplasm. Okay, then they causes the downstream signaling. So these receptors, the steroids, include the progesterone, estrogen, testosterone, cortisol. All of them are the steroids. Okay, aldosterone, which is secreted from the adrenal glands, kind of steroid. Okay, T3 and T4 are the important ones to remember. Okay, the thyroid hormone T3 and T4, they act through the intracellular receptors. Okay, they all are the DNA binding hormones. Okay, then vitamin A, D, E, K, they again have a cytoplasmic receptors, not the membrane. Rest for all other hormones, they have the membrane bound receptors, right? But for these hormones, you have the intracellular cytoplasmic receptors. Okay, and all of them will undergo then the this RAS pathway to cause the cell growth. Okay, so the easy one to remember, all the steroid hormones, they will undergo the cytoplasmic receptor pathway. Then comes the tyrosine kinase pathway, all the growth factors. Okay, like the insulin growth factor, fibroblast growth factor, platelet growth factor, epidermal growth factor, the TGF beta, the insulin, they all have the receptor tyrosine kinase. Every growth factor that you know, they have the receptor tyrosine kinase, which means whenever these hormones bind to the receptor, what's going to happen? The dimerization will occur, that will activate the tyrosine kinase, which will phosphorylate the tyrosine. After the phosphorylation of tyrosine, the RAS will be activated, which will activate the BRAF. Finally, the BRAF will cause the downstream signaling that will activate the transcription factors, and the growth of the cell will occur. Okay, so every growth factor that you know is the receptor tyrosine kinase. Now, every cell, which is a blood cell, okay, and every other, you can say like every protein or every hormone which is involved in the immune system and in your blood, right? They're all acting through the non-receptor tyrosine kinase. Okay, and the other important one to remember are the prolactin and the growth hormone. Just remember these two. Okay, the growth hormone and the prolactin, they act through the non-receptor tyrosine kinase, which is a JAK-STAT pathway. Okay, whereas the immunomodulators and the immune cells, okay, like the cytokines, interleukin 2, interleukin 6, interferon alpha, gamma, beta, right? GM-CSF, G-CSF, erythropoietin, thrombopoietin, even the cytokines released from the lymphocytes, okay, they all undergo the JAK-STAT pathway. So every blood cell and the cytokines, along with these two hormones, the growth hormone and the prolactin, they all undergo the JAK-STAT pathway. Okay, what's going to happen when they bound to the receptor? They do not have the intrinsic tyrosine kinase activity. Instead, the tyrosine kinase will be free floating in the cytoplasm. when the receptor dimerization occur, the tyrosine kinase in the cytoplasm, it will become activate, okay, by this JAK and STAT. They will undergo this pathway and they will cause the cell growth or other things. Okay, so how step 1 can ask you question on these pathways? They will give you a certain tumor, okay, and you must know that this tumor is releasing this hormone, and they will ask you what is the mechanism by which this tumor is causing the the growth of the cell, right? So they can ask you the mechanism. They will ask you that's how this what protein levels or what enzymes level could be elevated in this tumor to release this hormone. For example, let's say the growth hormone tumor, which is the acromegaly or a gigantism, you will get a pituitary adenoma, right? The growth hormone releasing tumor. So they will ask you under what response the growth hormone is releasing. So it would be the growth hormone, regulatory hormone. So they will ask you inside the cell what proteins will be in the high number, or what proteins will be activated, right? So it would be the cyclic AMP you will answer. Okay, if they ask you how does this how the growth is occurring in the cell after this acromegaly, so it will be the insulin like growth factor, right? They will ask you about the bone, they will ask you about the muscles, what enzymes or what proteins would be activated in the muscles in case of this tumor. So it would be the receptor tyrosine kinase. They can ask you about the fat cells, the adipose tissue, how does this the insulin resistance is occurring. So it would be by the direct activation of the growth hormone, which is by the non-receptor tyrosine kinase. They can ask you how this insulin-like growth factor is releasing from the liver. It is by the action of growth hormone, which undergoes the JAK-STAT pathway to release the IGF-1 from the liver. Okay, so that's why you need to remember every hormone and every pathway. The most important ones are the flat jump chuck because the confusion occur there. Rest all you can easily identify by just thinking about the action of the enzyme or the hormone, right? GMP, the vasodilation, you guys, ANP, BNP, you guys know. For the IP3DAG, just think about the constriction, the smooth muscle constriction. Every hormone which is causing the smooth muscle constriction undergoing the IP3DAG pathway. Okay. Every hormone which is a steroid or fat soluble hormone like vitamin A, D, E, K, along with this the thyroxine hormones, they are intracellular. Okay. Every growth factor that you know is a receptor tyrosine kinase. Every blood cell, every cytokine, along with the prolactin and the GH, the growth hormone, they work through the JAK-STAT pathway. Okay. Is that okay for everyone?
Yeah, yeah.
Okay, then we need to remember the signaling pathway for the steroid hormones. Okay. Like we discussed, the steroid hormones, they do not have any receptor on the cell membrane. Instead, they have the cytoplasmic receptor. So they can easily cross the cell membrane, enter into the cytoplasm. In the cytoplasm, okay, the receptor will be present and it is binded with the heat shock proteins. Does anyone remember about this heat shock proteins from the biochemistry?
Yeah, it prevents misfolding.
The chaperone.
Yeah, chaperone proteins. It causes the proper folding of a protein, right? And one example is also given in the first aid. A fungi, remember a yeast. Yes. So these the heat shock proteins. E. coli?
No. A bacteria?
It was
it in the back?
It was yeast. Yeast is a fungi, right? The
I don't
yeast shock
remember which
proteins,
fungi it was.
HSP1. HSP1.
Wait,
right?
sorry. Are you saying that there was a specific fungi, or sorry, I misunderstood that.
Actually, example is given in the first aid about the heat shock protein 1, which is in the yeast. Okay, and they're especially responsible for at very high temperature, they will cause a proper folding of the protein. Okay, at a very high temperature. That's why the heat shock. Okay, so you can remember the example. Don't worry. Okay, so these receptors are present with the heat shock proteins, which causes the proper folding of the receptors even at a very high temperature. Okay, and most of them are the zinc finger classes, and that's why I told you in the biochemistry lecture that zinc is just intracellular receptors. If you guys remember, like we discussed, is in the zinc deficiency, right? The zinc is responsible for the intracellular receptor function because all the receptors are the zinc finger motif class. Okay, Whenever the hormone binded to the receptor, okay, they will make the DNA binding proteins. They will make the DNA binding domains. Okay. Now the DNA binding domain, it will go to the nucleus, and in the nucleus, it will bind to the DNA. And where does it bind to the DNA? We have discussed that already.
Promoter regions.
Not the promoter regions.
Enhancers.
All the transcription
Factor.
Where does it
Transcription factor.
Enhancer regions.
Like I thought it binds to the factor.
Does it bind to the DNA?
I thought it binds to the
Enhancer
factor.
region. Yes. Okay. So what's gonna happen? Yes. Okay. The DNA. Again, please.
I thought it binds to the initial factor in the beginning.
Oh, no. Yes.
Your voice, I can't. Your voice is breaking.
Oh, I think my internet connection is kind of interrupting.
Oh, okay.
Is that okay now?
Your voice is okay. Could you please repeat once again?
See, what happens when that when this hormone, the intercellular hormone, or that or this steroid hormone, it will cross the membrane. It will bind to the intercellular receptors, which is in the cytoplasm. From there, they will make the DNA binding protein or the DNA binding domain. Okay, now they become DNA binding domain. Okay, they will go to the nucleus, and which is just be inside a gene, doesn't matter, right? So they will bind to the DNA and they will cause the formation of mRNA. Okay, and they will cause the protein synthesis. Okay, let me just reconnect my internet. Just
okay.
Okay. So let me repeat this point again. So there's a hormone which is a lipid soluble hormone or the fat soluble hormone. Okay, it can easily cross the membrane of the cell. It will bind to the receptor which is in the cytoplasm. After binding to the receptor, they will make the DNA binding domain. This receptor with the hormone, it is known as the DNA binding domain. Okay. Now what gonna happen? This DNA binding domain then go to the nucleus. It will bind to the DNA at the enhancer sequence. And remember one thing about enhancer, that it can locate it anywhere, far away from the gene, within the genes, and where in the gene. Does anyone remember? If the enhancer is located within the gene, then where in the gene it will be located?
Upstream.
Not
It can be
upstream,
located
down.
above or below.
Yeah, it can locate it anywhere, but within the gene, if it is located within the gene, I'm saying, after the promoter, the gene is started, right? Within the
Yeah.
gene, where does it located? If it is located in the gene, in the exons or in the introns?
Introns.
Exactly. Yes, please remember this fact. Stefan is likely to ask you this. Okay, if the enhancers are located within the gene, that means it is located in the introns. So this domain will be binding to the enhancers. Okay, after binding to the enhancer, they will speed up the transcription process. Okay, they will cause the formation of mRNA. Okay, then mRNA go out of the cell, they will form the proteins, and further response will be generated. Is that okay for the steroid hormones?
I'm sorry, I missed it. Why is it important that our enhancer regions be in the introns? Is it because we want to keep them inside the nucleus?
Because if they're located in the exons, then tell me
It'll get translated in the protein.
They will get translated. You don't want that, right? They will interrupt the gene sequence, because exons are the real part, which is a real thing for the gene, right? You don't want anything like which is interrupting the gene.
Okay, so you want your final product to not have.
Yeah, exactly. And introns are the sequences which cannot be translated, right? Because they will be spliced out by the spliceosome complex, right?
Yes.
That's why this the enhancer will be located only in the introns, not in the exons, because exons are the real sequence for a gene.
And the GRF, is that the answer?
Yeah.
what is the GRF in this? You made a notation that GRF, is that my enhancer example?
So
Or
it's GRE. I don't remember why this GRA
okay.
I written it here.
Okay.
I think it is for the enhancers only. I don't know.
Okay.
I've forgotten it. Okay, so other thing that
One
you asked.
second. What was the enhancer? The enhancer-like elements are located in the introns. Is that what it is?
It is kind of a sequence in the DNA which is located within the introns, or it can be far away from the gene, upstream, downstream, anywhere. Okay.
Okay. So the important thing to know is that you said the enhancer-like element, right? That is the thing that's in the intron.
Yeah, they actually enhance the transcription process. They will speed up the transcription process. Okay. That was the name enhancer.
Okay, thank you.
Okay, other important thing, like we have discussed, that this estrogen can actually increase. Okay, estrogen can actually increase all the protein binding carriers. Okay, or any hormone binding carriers, I must say. Okay, or any ion binding carrier. So whenever you have a high estrogen level, okay, you always have an increased level of any protein or any hormone or any ion binding proteins or a carrier. Like similar thing is exist for these steroids also, because the steroids, whenever they enter the blood, okay, they are binded to a certain carrier. Okay, in this case it will be the sex hormone binding globulin, SHBG. Okay, so similarly, whenever you have a high estrogen level, you can have a high SHBG count, and that means the free level of the testosterone or or the other steroids, it would be decreased. Okay, sorry, the free level will be decreased and the total level will be increased, just like in case of thyroid. Remember, we have discussed that in case of thyroxine, it would be binding to the thyroid binding globulin, right? And whenever you have a high estrogen, what's going to happen to thyroid binding globulin? It will be increased, right? So just remember, whenever you have a high estrogen level, every carrier in your blood, okay, whether it is a hormone carrier, whether it is a steroid carrier, whether it is an iron carrier, okay, they will all be increased with the estrogen therapy. So the total level will be increased and the free level will be decreased. So whenever you have a whenever you have a steroid, whenever you have a high estrogen levels, what's going to happen? Free testosterone will be decreased, and because the free levels are responsible for the activation or the deactivation, right? These are the free levels which are kind of active in the body, so you will get the gynecomastia. In case of women, if they have a low estrogen, what's going to happen? The SHBG will be decreases, and as a result, the free testosterone will be increases. Patient can get the hirsutism. In case of OCP, in case of pregnancy, you will have a high SHBG, which means the total level will be increased, but the free level will be decreased. And similar thing you can get in case of transferrin. If you guys remember, the transferrin is responsible for the transport of iron. It is an iron carrier. If you give the patient estrogen, this transferrin level can rise. Okay, and as a result, the free iron level in the blood could be decreased. Okay, and you can get the anemia. Is
Can
that
you
okay?
repeat it? Transparent. Repeat the transparent.
You will study the data in the. Don't worry about that. You will study later in hematology section that if you give the patient estrogen, the transferrin levels will be increased, and as a result, it will bind to more iron, right? And as a result, the free iron level in your blood would be decreased because of the high estrogen therapy. Okay.
Okay.
So every transporter in your blood, every carrier in your blood, like I said, it would be increased because of estrogen. Okay, not a specific ones, every carrier. So a easy way to remember, okay, every steroid carrier, every thyroxine carrier, every iron carrier, they all will be increased because of the estrogen therapy. Okay, so total level will be increased, but free level will be decreased. Okay.
Okay.
That's all about the physiology of the endocrine. Any doubts so far?
Can you please explain the zinc finger motif that you have written on the
Zinc,
figure?
these are the receptor classes. Okay, they are binding to the zinc. Okay, and zinc is responsible for the maintenance of these receptors, actually, right? So that's why known as the zinc finger classes. They have a finger-like structures. I don't know. Yuval has a diagram on it. I can display you tomorrow if you want. Okay, but Yuval has a very beautiful diagram for the zinc finger class receptors. Okay.
So it's a special class only for the hormones.
Yeah, it
or
is. Yeah,
steroid hormones?
it is a special class for the cytoplasmic receptors. Okay, so every hormone which is a steroid one, they will bind to these class of receptors, the zinc finger motifs. They are finger-like structures, okay, and which are binded to the zinc, and that's why the name zinc finger.
Okay. Thank you.
Okay. Any more doubt?
No.
I think we should wind up here, and from tomorrow we will start the pathology. Okay, we will finish the pathology tomorrow, and as well as the pharmacology tomorrow. Okay.
Chaudhary, I have one question.
Yeah, do ask.
The Prader-Willi syndrome and ghrelin association again.
Please repeat it again.
The Prader-Willi syndrome and ghrelin. Could you repeat that association?
Prader-Willi syndrome. Okay, it is a syndrome in the biochemistry. We'll study that about it. That it's a syndrome of the mutation in the chromosome number 15. Okay, and I know I have to go so far. Just give me a second. So you have one thing, one phenomena, which is known as the unipetal disomy, in which two genes are come from one parent only instead of both the parents, right? What happened? There are certain genes in the chromosome number 15 which are activated in the female chromosome, and certain genes which are active, which are inactivated in the male chromosomes. Okay, so certain okay. So what happens? Because only one gene would be activated, will be active in the female chromosome, and one gene will be active in the male chromosome for a certain allelic. Like say, let me annotate it. You have a one chromosome number 15, and you have another chromosome number 15. Okay, this one comes from the male, and this one comes from the female, let's say, right? Now what's going to happen, there are certain genes on this chromosome number 15 from the male, okay, and certain genes from the female. Same genes, but same alleles, right? Different genes, but same alleles, okay? Now what's going to happen, one allele randomly, not randomly, it is a very specific thing, that one gene or one allele from the female will be inactivated, okay, in the individual, okay, and one allele from the male chromosome will be inactivated in the individual. So as you can see on the chromosome number 15, okay, only one gene is from the male is activated, and one gene from the female is activated. Now what's gonna happen if I get two chromosomes only from the male, or two chromosomes only from the females? Let's suppose that this is a case of example of females. Okay, both the chromosomes are from the females only, which is known as a unipetal disomy. Now these two genes are still present on both of the chromosomes. Now by default, if it is the genes which are inactivating in the males, sorry, which are inactivating in the females, right? So this gene will be knocked out in the female by default. This gene will also be knocked out in the female by default. So you have no copy of the gene left, right? And this can cause the Prader-Willi syndrome. Okay, a certain gene, okay, which will be knocked out if both the female copies will be present, right? So this can lead to the Prader-Willi syndrome, in which you have the hyperphagia, you will have the hypogonadism, okay, you will have the and you will have the intellectual disability, okay. And similarly, if normal condition is there, one from the male come, one from the female come, the female one will be randomly will be by default knocked out. And what's gonna happen if the mutation to this gene is happened? If the mutation in the male one will happen, then this gene will also be knocked out. So no copy of the gene is left, and then patient can again also get the Prader-Willi syndrome. Okay, and a classical triad in which you will get the hyperphagia, obesity, hypogonadism, and the intellectual disability. And you can also refer to the first aid page number. Let me check. It is on the page number 58 of the 2020 edition. First aid page number 58, the Prader-Willi or the Angelman syndrome. Okay.
So if you knocked out the gene, then you will have increased production of ghrelin?
Yeah, exactly.
Okay.
Very increased production of the this ghrelin, okay. So please remember, for the Prader-Willi, it would be either two copies from the females only, okay, or it would be a mutation in the male one, because by default, the female gene is going to knock out. Okay, so if both the copies come from the female, that the gene which is causing the disease will be knocked out, right? It will cause a disease. If the mutation will be happen in the male part of the gene, then it can still be knocked out and can cause the Parater Brai syndrome. Okay.
Okay.
And similarly, if both the copies from the male come, okay, or a mutation is occur in this gene which is activated in the female part, if this part will be knocked out, then you will have the Angelman syndrome. Okay.
Okay. Okay. Thank you.
Any more doubt? Anyone?
No.
Okay. Thank you so much, everyone.